I'm Beth Rontel. And while we're waiting for everyone to come on, how about you just announce yourself in the chat and say where you're from? It'd be really nice to get to know as many people as possible. So let's start seeing some. Oh, Rebecca from Ann Arbor. I went to undergraduate school in Ann Arbor, Rebecca. Good morning. Hello, Stephen and Desiree and Ken. Oh, thank you for putting your names in the chat. From people from everywhere. Go Blue. That's right. That's right. Yep. Every day at 4:30, I would hear the Michigan Fight song being practiced near my apartment. And good morning from Cassandra. Thank you. And Lori. Oh, it's so nice to have everybody sign in and say hello. This is great. Jeffrey, more people from Michigan, my hometown. I don't live in Michigan anymore. It's just a lot of friends and family still there, though. And Angela, Chrissy, Jennifer from Brisbane. Wow, that's where my sister-in-law is from. All right, Sharon, Wendy. Wow. Well, we're just going to keep doing this for a few minutes because it takes a lot of people time to just get on and settle in. And so we will start in just a couple minutes. And excuse me while I bend down out of the camera to pick up the pen that I just dropped. Melissa from Ohio and Jessica from Baltimore. Oh, it's so great to see all these people, all of you. Melanie from Atlanta. And Jason, this is great. All right. Sharita, what a pretty name. And Holly. So we'll just give it another couple minutes and then we will start. Are there handouts for the webinar? Somebody just asked. You know what? I'm really glad you said something. There are handouts for the webinar. The PowerPoint just recently was updated. So if you go to the PESI site, you can download the PowerPoint manual and the practice forms. There's 2 practice forms and there's also a bibliography. And you can download all of that. And it looks like our Zoom host is typing in an answer. Welcome, Elizabeth from Ohio. Oh, wonderful. I'm glad, Lily, you got what you needed. Terrific. All right. So if you had told me over 20 years ago that I would become known as the documentation wizard when I started my clinical career, I would have told you to go get your head examined, and I would have told you some wonderful therapists to go see, because I would have said, you are crazy. There is no way that I believed or even really thought about documentation having any relevance to good clinical work. But if you fast forward many years, where I supervised clinicians for 11 years. I worked at the same clinic for almost 16, and I supervised for over 11, and I supervised over 50 clinicians. And I had to review their documentation, and I had to sign off on it. Now, if I have to sign off on it, my licensure goes on that signature. You can believe it was going to be done right. So I had to learn it. It did not come naturally to me. I really did struggle with it. It's because I struggled with it so much that I learned it really well. I learned it so well that the clinicians who were struggling to learn it from other supervisors were given to me to teach them. And I remember one of my supervisees was transferred to me and told that if she didn't learn it in 3 months, she would lose her job. Now, she was a long-term clinician. She really struggled with the process. She walked into my office with the tears streaming down her cheeks and sat down, and I said, look, I really want you to learn this, and I'm going to do everything I can to make sure that you do, because I don't want to lose you. So she was given twice a week for 3 months to see me. And inside of 2 weeks, meeting twice a week, she had a list of action items that is, my hands go off the screen, that was 3 pages long. She was completely caught up. She knew how to do it. And she knew how to do it so well, she could actually teach other people in the clinic how to do it. So I am going to teach you based on what I taught her. And what I taught her was a formula. I taught her how to take her clinical skill and intuition and put it into an insurance-friendly set of documents. I see another question about handouts from Dorothy. So yes, Dorothy, please go to the PESI site and download your handouts. They're there. Okay. The other thing that I was absolutely determined to teach my supervisees is that good documentation actually is a contribution to clinical work. It doesn't have to be just an exercise in annoyance. If we have to do it, it might as well help us with our work, right? So that's what I'm going to promise you today, that the documentation that you learn will help you with your clinical work. Could I please hold off presenting while we're trying to get things printed? That is a really good and reasonable request, but here's what I will tell you. The first part of this is not so much information. That's coming shortly. The first part of this is really for you to get to know me better and me to get to know you better. So here's what I would like you to do. I would like you, while you're trying to print, and I know that it's going to be difficult for you, and I apologize, but if I hold it up, we're going to get way behind. What I'd like to do is I'd like to hear from you and get a sense more of not just where you're from, but what your licensure is. Are you in private practice or in group practice? Do you work at a clinic? Are you an administrator? And how many years you have been in practice? Thank you, Drew, for saying that. That's terrific. So everybody take a look at the chat so that you can see what Drew wrote. So Lily, wonderful clinical psychologist for 20 years. Another clinical psychologist for 26, an LPCCS for 11, solo practice, 21, 2 years, Beth Wheat, 35 years, another 13 years from Mary, over 20, Kier, over 20, Brenda, 10. Okay, and new to solo practice. So smart to take this course when you're starting your practice. Working with vets for 3 years, 15 years. Okay, 10. Okay, and a lot of private practice, state hospital for 11. Oh, now they're coming in really quickly. Okay. Fresh out of social work school. Great. Congratulations. Chandra, 10 years. Practice marriage and family therapist for 35 years. Yep. 25 years. Are you, if everybody is following the chat, are you getting a theme here? A huge number of therapists who are on this, taking this program today, have been in practice for over 20 years. So I want you to know that you are not alone. In fact, most of the people who take this workshop have been in practice for over 20 years. And the reason you're taking it, and of course, the reason everybody takes it, is because this was not taught in graduate school. And the reason it was not taught in graduate school is because what the professors say is when you get out of school and you start working at an agency, every agency has their own population and has documentation that is consistent with their own document, with their population. And that is absolutely true. They do have their own population and they will have specific documentation needs related to it. However, there are standards, and you are going to learn the standards for documentation that go across the board, no matter what kind of population you work with. Ken, you are a clinical director of behavioral health services and a social worker for 20 years. Wow. 8 years dually licensed. Fabulous. Jackie Lynn. Okay, Drew, there's another question about the handouts. It's on the chat. And somebody else cannot find the handouts. I am really sorry, everybody. Okay. So I want to go a little bit over protocol. If you have specific questions, please write them in the Q&A. If you are answering a question that I asked, please write it in the chat. And that way I will be able to pay better attention and to what I need to pay attention to. Thank you, Drew, for that information. So, all right. Now, here are some required slides that you need to take a quick look at. And I will let you just read it briefly. And what I'd like to hear from you now in the chat is, now that you've heard from me, is how do you feel about documentation? What brought you here? Why is documentation so daunting? I'm assuming it's daunting or you wouldn't be here. What do you struggle with? So let's put it all in the chat. With overwhelm, yeah, I'm sure there's a lot of people who feel overwhelmed. Can't stand it. Thank you, Wendy Lou. Moving to confusing. Yep. How much to write? I bet. Am I writing too much? Am I writing too little? I have anxiety about what I could currently, what does that say? Currently not doing and should be doing. Yes. Also maintaining confidentiality, making sure I'm capturing what's necessary, but not over documenting. Yep. Also to remember clients' issues, afraid of being audited. Yes, definitely. It takes too long. It's the worst part of my job. Well, I hope by the end of this, it's not the worst part of your job. How to be concise, because I write way too much. I bet a lot of people write way too much. Let's see, finding time. Yes. Yes, that's right. Audits from, has anyone ever been audited? If you would be willing to just type in whether you've been audited or not. I know it can be sensitive, but lots of people have been audited. Concurrent documentation makes it difficult to capture everything I want to note. Yep. Not everybody does concurrent documentation. If you don't know what that means, concurrent documentation means you write your notes while you're in your session. Thinking you're doing what is right and then getting audited and finding out it's wrong and it's expensive. That's absolutely true. Let me scroll down. I'm not going to be able to read all of them. Feels like I need to learn haiku. That's good, Wendy Lou. That's good. Yeah. Yes, electronic record programs have too many unnecessary sections. They can be confusing. Some people love them. I struggle with the language. It's time consuming. I think you guys are going to like what you learn here. Yes, you are audited by the state. Yes, Laura. Yeah. Yes, Jeffrey. No, I'm glad you have not been audited, Susan. Thank God. So for those of you who have been audited, yes, not yet. Yeah. For those of you who have been audited, I'm really sorry because it really is anxiety provoking. It would be anxiety provoking for me if I were audited. I work with a lot of clinicians who are audited. They contact me when they get the dreaded letter. And so I know how anxiety provoking it is because I wind up getting all the counter transference from it. Yep. Okay. I can't read all of the responses, but yeah, Medicare can go back a long time. That is right, Diane. I once helped somebody through a 4-year retrospective Medicare audit, and Medicare is auditing more this year than they did last year, which is really too bad. So perhaps this is you. I know a lot of therapists who would rather do this than write their notes. But why document? Why is it so important? So why don't you write in the chat? I'm trying to keep up with all of your comments. Okay. For those of you who are writing in the Q&A, it would really, really help me if you wrote it in the chat and leave questions for the Q&A. That's going to be how I manage myself and make sure this goes along well. All right, so, oh, this is a very good one. Bethany says, I've been audited by insurance, but I am mostly concerned about documentation for legal purposes where notes get subpoenaed. We're going to cover that. It's all part of it. All right, so if you would write in the notes, why document? Besides audits, besides legal reasons, why else do you document? And another way to ask that is, how is it used and who's going to read my notes? To justify medical necessity for treatment, so I can remember what happens session to session, because if it's not written down, it didn't happen. We're going to go over that one, Laura, because that one confuses people a lot. Yes, to track progress on goals, to remember from session to session, for my own reference, for continuity of care, yes, to show progress, proof of care, yep. And so who can read your notes? For school-based, for IEPs, yep. I've sat in plenty of IEP meetings. To justify billing for other providers, that's right. To review progress, oh, that's good. So you do use your notes for clinical reasons. To track progress with a client is a clinical reasons. Yes, for workman's comp, for Social Security, for disability, for insurance auditors. Yeah. Yes, insurance auditors are going to read your notes. Who else? That's right. Our patients or clients can read our notes, and not just since the Cures Act. We've always had open notes. So the next question I usually get is, are 2 sets of notes allowed? And here's what I can tell you. Yes, in most states, 2 sets of notes are allowed. If you have 2 sets of notes, they have 2 different names. They're called progress notes and psychotherapy notes. Progress notes are what I call the medical record, and psychotherapy notes are what I call the memory notes. And I call them that. I call them the memory notes because they trigger our memory from session to session. And I call progress notes the medical record because that is what they are. They're the medical record. So I never understood why anyone would have 2 sets of notes. Can you explain? Absolutely. The reason that people have 2 sets of notes is because there is information that you want to remember that is confidential, and it does not belong in the medical record. That's why you have 2 sets of notes. I hope that answers your question, Diane. All right. If you have 2 sets of notes, they must be stored in 2 separate places. So if you're using an electronic system, then they usually have a place to put your medical record and your memory notes. So if you use an electronic system, that's what you do. And it is understood that anyone who requests your notes only has access to your medical record. If you store your notes on your computer, like I do in a password encrypted program, then I keep my medical record on my computer and my memory notes in a paper file. If your notes, if your memory notes and your medical record are in the same file and your file is requested or subpoenaed, you have to turn over the entire thing. You don't want to do that, so keep them separate. A judge can it's a couple of yep. Okay. Can psychotherapy notes be subpoenaed? Yes, they can. And workman's comp can also request your notes. But if workman's comp requests your notes, then the client has to sign a release. If an attorney requests your notes, a client has to sign a release. The only way you have to turn over your notes in a legal situation is if they are subpoenaed. Diane, I don't know the answer to that. Are we the only profession who keeps two sets of notes? I'm sorry. I don't know the answer. And how long do I keep them? We're supposed to keep our notes for 7 years. That might change by state, but my understanding is 7 years. For kids, until they're 18, I think a couple years past being 18, so about 20. And why do I write them? Well, we actually talked about why we write them. We write them for our own memory. We write them to review with clients for progress. We write them for the insurance company because it's the only way we can guarantee being paid. We write them for disability, for workman's comp. We write them for probation officers. We write them for other providers. We write them for continuity of care. So we actually have a lot of masters. So we have to be careful what we write. And if we know that we have a workman's comp case, or we know that we're writing for a disability claim, then we have to keep that in mind when we're writing. All right. Do texts and emails with clients belong in the medical record? That is a good question. I keep all of my texts. I don't keep my texts in the medical record. I do keep emails in my medical record if there's anything clinical that comes through my emails, and that is in my informed consent. The psychotherapy notes, are the psychotherapy notes able to be subpoenaed? For an electronic medical record, psychotherapy notes are kept separately from process or progress notes. The progress notes or the medical record are what can be subpoenaed. Psychotherapy notes can be subpoenaed by a judge. You have more ability to withhold those notes, but you may not be able to. Okay. I'm probably going to not answer so many questions right now because I want to make sure that we are humming along here. I love your questions. They're really good. And when I do this face to face, I actually, people get to ask their questions verbally. Yeah, you're welcome, Jason. All right. Now, there are also people who wonder, should I write psychotherapy notes? If I don't take insurance, should I write psychotherapy notes? So on the left is, if you take insurance, go right down to, yes, write your notes. If you accept PPOs, if your client is using a PPO, you still have to write notes. The insurance company can still demand your notes because they're still paying your bill. And no matter what, writing the notes will help you maintain professional integrity, and it can help protect you against legal action. So even though you might rather clean the toilet, write your notes. And also, don't save your notes to do all in one day. Because if you do, like when I was supervising, hands down, every single one of my clinicians wrote their notes on a Sunday. Now, to be fair, we did home visits, so it was really hard to write your note after a session, and you were tired when you got home. But if you see 20 clients, and that at this point for most people is an average to a low average caseload, and it takes you 5 minutes to write a note, you've got 100 minutes, you're spending almost 2 hours on a Sunday. And once you take a break for lunch and you take a break to, play Scrabble on Facebook and check out all your friends, and you spend a little bit of time with your kids or go walk your dog, 5 hours have gone by, and it's just a horrible way to spend your Sunday afternoon. Please clarify when you are referring to medical record versus the therapy notes. The medical record is what I am teaching you today to write. Those are the progress notes. Medical record, progress notes, same thing. Memory notes, psychotherapy notes, what you write for yourself. Okay. Writing notes is so important that it is mentioned in the Code of Ethics for every single profession. So for the APA, psychologists keep records, provide good care, assist collaborating professionals, ensure continuity of professional services, provide for supervision or training, provide documentation required for reimbursement or required administratively under contracts or laws, and document any decision-making, especially in high-risk situations. That's one of the things I like that the APA includes, the issue around high-risk situations and collaborative work. And it allows the psychologist to effectively answer a legal or regulatory complaint. The American Counseling Association, they include things like counselors need to include sufficient and timely documentation to facilitate the delivery and continuity of services. Counselors take responsible steps to ensure that documentation accurately reflects client progress and services provided. The NASW social workers should take responsible steps to ensure that documentation in electronic and paper records is accurate and reflects the service provided. So they're also reminding us that it's okay to keep paper records. Social workers should include sufficient and timely documentation and records to facilitate the delivery of services and to ensure continuity of services provided to clients in the future. American Association of Marriage and Family Therapists maintain accurate and adequate clinical and financial records in accordance with the applicable law. And the National Association of Addiction Professionals states that addiction professionals and other service providers shall create, maintain, protect, and store documentation required per federal and state laws and rules and organizational policies. So this isn't the only thing. These quotes I've taken out aren't the only things that your codes of ethics say. I took out just ones that I wanted that were really well said, and so that you could see just how important clinical documentation is. Okay, so we write for different masters. Here again, audits, disability claims, workman's comp, social services, subpoenas, board complaints. I want to say something about board complaints. We actually get more board complaints than we do subpoenas, and it's really sad. We actually work in a high-risk profession because there's suicide, there's child neglect and abuse, there's elder neglect and abuse, and we need to reduce our liability whenever it's possible by keeping really solid and accurate records. And if we don't, we can get a board complaint for medical negligence related to poor, let me start that again. You can have a board complaint about one issue, and then the board looks at your documentation and they may say that they're not finding anything against you for the complaint that was filed against you, but they don't like they don't like your documentation, and you can get sanctioned for that. So, yeah. So board complaints. So we write, so like we said, like I'm saying, we write for lots of different masters, including our boards, and we write for our clients. And of course, we write for ourselves. Yep. So you can run, but you can't hide. Got to do them. Got to do them. All right. Learning objectives. One is to describe how to apply the clinical documentation process to write effective treatment plans, session notes, case consults, discharge and diagnostic summaries, no matter what documentation system you use. I am going to start teaching you with the treatment plan. You would think, because the diagnostic summary is the first thing that we really write, that that's where I would start. But I will tell you, I tried that once, and it was actually a distraction from what the real work is, because you all know how to write a diagnostic summary. You're good at that. You just need to know what information to put in your diagnostic summary. The first thing we're going to start with is the treatment plan, because that is the document that causes the most confusion. Well, it's not the most confusion, it's probably the most difficult. And what I'm going to do is teach it to you as a formula, so that you're going to be able to turn your clinical intuition and skill into a formula that will reduce your chances of getting sanctioned and increase your chances of passing an audit. After the treatment plan, we're going to go to the session note. The session note also can be confusing to people. Like, I write too much, I write too little, I don't know what to include. You're going to find out what to include, and find out just how little you need to include, except under certain circumstances, and then how much you do need to include under the unusual circumstances. After the session note, you're going to learn about how to write a case and collateral contact note, and after that, a discharge summary, and then finally the diagnostic summary or the intake summary. It has lots of different names. Okay. You'll learn how to you'll be able to demonstrate how to translate your work into the behavioral language required by insurance companies, no matter what therapeutic modalities you use. And you'll apply the golden thread to justify medical necessity. You'll be able to explain how to write clinically useful notes that document progress and protect confidentiality. And you'll be able to identify potential clinical, legal, and ethical red flags in the documentation process and how to avoid them. Now, what this workshop is not about. It's not about billing and coding. Billing and coding overlap with documentation, but billing and coding can be very complex. That's why I hire a biller, frankly, even though my billing is not complex. But billers actually take trainings in order to do the billing. So I will mention a few things about billing, but it's not about billing or coding. This is also not legal advice. This is educational only. If your notes come into question for any reason, for example, they're audited, they're requested by SSI or SSDI or Workman's Comp, if they are subpoenaed, or you need to testify in court, please review your state guidelines or consult with an attorney. Okay. The documentation is to Medicare standards. Now, why Medicare standards? The federal standards are incredibly strict. If you can pass a Medicare audit, you should be able to pass any audit. Most commercial insurance companies follow Medicare standards. The only time there are exceptions to this are for Medicaid insurance companies. They sometimes have state-specific requirements. You will need to go to your state regs in order to find out what those state-specific requirements are. All right. So what is medical necessity? And we're going to read it together. This is the definition that when I first started teaching this course in 2012, I had to hunt for the definition of medical necessity. Now all you have to do is, Google medical necessity and it will come up right away. That's how much airtime the issues of medical necessity have gotten. All right. Healthcare services that a healthcare provider exercising prudent clinical judgment should provide to a patient for the purposes of evaluating, diagnosing, or treating an illness, injury, or disease, or its symptoms, and that are in accordance with the generally accepted standards of medical practice. They are clinically appropriate in terms of type, frequency, extent, site, and duration, and considered effective for the patient's illness, injury, or disease. They are not primarily for the convenience of the patient or healthcare provider, physician, or any other healthcare provider, and not more costly than an alternative service or sequence of services, at least as likely to produce equivalent therapeutic or diagnostic results as to the diagnosis or treatment of that patient's illness, injury, or disease. Generally accepted standards of medical practice means standards that are based on credible scientific evidence, published in peer-reviewed medical literature, generally recognized by the relevant medical community, physician and healthcare provider specialty society recommendations, the views of physicians and healthcare providers practicing in relevant clinical areas, and any other factors. Okay, so first of all, this is a gotcha moment. Any other factors? This means if there's something we forgot and left out or strikes our fancy, then it's a factor. And here is another issue. Standards are based on credible scientific evidence published in peer-reviewed medical literature. generally recognized by the relevant medical community. This does not, what I'm going to say does not mean that I don't believe in or accept the limitations of peer-reviewed and validated techniques. What I'm going to say to you is, if we never used anything new that was not peer-reviewed and validated, we would never progress as a profession. If open heart surgery was not tried prior to it being a standard of care, we would never have it. So I just really want you to know that this definition is, one, restrictive, and two, not helpful in terms of learning how to operationalize it. Medical necessity, what it is and what it is not. It is a coverage and payment concern. That's really what they're concerned about. It is not a clinical or patient care description. However, in order to protect yourself in all the ways that we were just talking about, and in order to do a good job so that if you showed your client the documents, the notes and the treatment plans, you need to learn how to write them. You said, I'm just giving you another reason to learn how to write them. You still need to learn how to write them. It's not just about coverage and payments. Okay, so here's a checklist that medical necessity. The client must demonstrate symptoms consistent with the primary DSM-5 diagnosis of a psychiatric disorder and or substance use problem. The client must be motivated and engaged and agree to comply with the treatment plan and have a system in place to ensure follow through with the plan. Remember the words motivated and engaged. Maintain a current level of functioning through outpatient treatment. The client must have impaired level of functioning in areas like self-care, work, family living, social relations, and outpatient care will help increase the level of functioning. So we do it to help increase the level of functioning. And the client will experience increased intensity or duration of symptoms with a diagnosis of mental illness and or substance use without treatment. So we see people to increase level of functioning and to keep them stable. What this refers to is keeping them stable. And that, by the way, I took off the Tufts Health Plan website. Tufts is a major insurance company here in Massachusetts, where I am. All right, so now what is the golden thread? Anybody not hear about the golden thread? The golden thread's a really important element of documenting medical necessity. All right, well, let's just, not familiar. Okay. All right, if you learn nothing else but how to document the golden thread, or how to use, not document it, how to do your documentation using the golden thread, you will have learned a great deal. I will consider myself successful. All right. This will make a lot of sense once you hear it. Each element in the therapeutic process, from intake to discharge, must be clearly documented so that the connection between all aspects of clinical work uh, flow logically from one record to the next. So from intake to discharge. If the golden thread is maintained, each document will support each decision, intervention, and note, contributing to a complete record of client care, one that reflects your work with integrity because you wrote the note, is respectful of client confidentiality, will help protect you from legal problems, will help you pass an audit, and get reimbursed by the insurance company. That is the golden thread. Everything connects. Now, the golden thread not only runs between documents, it runs inside of documents. I am going to give you a visual of how the golden thread runs between documents. The first note that you write is your diagnostic summary. And you have your presenting problem, your symptoms and the behaviors that show the symptoms, your diagnosis, and why treatment is medically necessary. Now, this isn't everything you put on the diagnostic summary. When I say the presenting problem, I'm also talking about all the history that goes into it. But these are the basics that go into the diagnostic summary. Then from the diagnostic summary, you write a treatment plan. So you're repeating the diagnosis and the presenting problem with the symptoms and behaviors, but you're adding goals, objectives, intervention, and eventually progress. And then you repeat why treatment is medically necessary. Then we go to the session note, where we repeat the diagnosis, the presenting problem with the behaviors. Then we have interventions. We have a subjective report, an objective report. An objective report in a session note is different than the objectives on a treatment plan, and we're going to cover it all, so don't worry about being confused now. And the assessment. So in the session note, we add subjective, objective, and assessment. We progress, and we continue with medical necessity. Then we have a case consultation where we have the diagnosis with the presenting problem, and then we include the reason for the consult and any follow-up information. And then finally, the discharge summary, which is a review of the treatment. It's basically a review of your treatment plan. And the reason for discharge is added, and then any recommendations post therapy. So this is a visual of what the golden thread, how to conceptualize the golden thread weaving between documents. Here is how medical necessity and the golden thread fit. Here's how I've conceptualized it. Each session is an experiment. The hypothesis is the diagnosis. The diagnosis is supported by evidence. The evidence are the behaviors that demonstrate the symptoms. And if you are confused about this right now, you're in a really good place because you're wondering. It's exactly what I want you to be doing. What does this mean? We're going to cover all of it. The diagnosis is also supported by the process. In other words, the goals and interventions and objectives are the process of therapy. The process shows progress or lack of it. The progress justifies and informs future treatment. And medical necessity is your conclusion of the experiment. So here's your conclusion. Continued treatment is medically necessary to address symptoms, reduce them, stabilize them, manage chronic ones, improve functioning, maintain gains, prevent decompensation, and prevent a higher level of care. Does that all make sense? Can you show previous screen again? I'm sorry, I don't know which screen you're referring to, Elizabeth. And I'm going to ask that you. Okay, great. It makes sense. Great. Thank you. For timing, we really need to move on. I'm sorry. I don't know when you asked that one. Oh, the one that shows. All right, I will do it. The one that shows the flow. It's very, very quick. There it is. That's the flow. I said I wouldn't, and then I said I would. I'm a soft touch. Okay. So please don't try and write it all down because you can download the manual. All right, you're welcome. All right, here we go. Close your eyes while I scroll through this so you don't get dizzy. All right, what is a treatment plan? Some of the questions I'm getting will be answered later on, so don't worry. If I don't answer them now, I just check them. If I don't answer them now, I'll answer them later. So what is a treatment plan? And normally I take responses when I'm doing this in person, but thank you, Rebecca. But I'm actually just going to tell you. It's a written document stating a client's presenting problems. Doesn't that make sense? It outlines the goals and the strategies to assist the client in overcoming his, her, or their mental health issues. And it documents the progression of therapy. Okay, I am getting a bunch of comments in the chat that this program, that talking about documentation creates a lot of anxiety. I really get that. That's part of why we had the conversation at the beginning. And actually, that is the reason we had the conversation at the beginning, because people are anxious. What I want to ask you to do to manage the anxiety is literally put your feet on the floor and breathe into your belly and remind yourself that you know what you're doing as a clinician. And though I'm saying things around board complaints and audits that can be scary, you actually know what to do. By the end of this, my hope is that you will go, oh, this isn't as difficult as I thought it was. There's rhyme and reason to this. I can do this. I have taught probably thousands of people, and I open my email and I get thank yous. I understand now. Thank you so much. I don't ask for them. I just get them. You will get it too. All right. Here is what the golden thread looks like in a treatment plan. Now, this visual may not make a whole lot of sense now, but I'm going to show it to you again at the end of the treatment planning session. And it will make a lot of sense then, but I want you to see it now. Let's say we have 3 problems. Here's problem A. Problem A needs to show up in the goal, the objective, the intervention, and progress. The same thing with problem B, and the same thing with problem C. There's also something that I refer to as barriers to treatment, or the biopsychosocial stressors, or the things that people come into session talking about. They need to show up as well. Now, I'm going to If you don't understand what barriers are now, don't worry. You will by the end. I've got a whole section on what barriers are. Okay. What is needed in a treatment plan? This is a checklist. For the most part, I'm just going to run through the checklist, and there'll be a couple of things with brief comments about them. And most everything else is going to be talked about in detail after I run through the checklist. And I apologize about the phone. Nothing I can do about it. At some point, there's probably going to be somebody mowing the lawn or a leaf blower out front, somebody blowing the leaves. And best case scenario, you'll hear a lot of birds chirping. All right. So we need the name and the date of birth. And I put client number. Now, client number is actually not needed for private practice therapists. But if you're working in an agency or you're working in a group practice where you have the chance of having somebody have the same name and date of birth, a group number is really important. And the name and the date of birth need to be on every page of every record. So even if you've got a note that is 2 pages long, or a treatment plan that is 2 pages long, or your intake note that's 5 pages long, your name and date of birth has to be on each one of them. You need to have the review dates on your treatment plan. For how many months is this treatment plan review? Are you doing a 3-month review? Are you doing a 6-month review? Or are you doing a year review? Are you writing your treatment plan for a year? Now, in private practice therapists, the standard is 1 year. Medicaid wants every 3 months. Medicare wants every 3 months. However, I worked in a clinic that negotiated with Medicare and Medicaid to have them done every 6 months, because change for the clientele that we were working with didn't happen very quickly. But the point is, you need to have your review dates. And when you're writing an initial plan, you will have your review from, picking a date out of the air, January 2nd, 2021 to January 2nd, 2022. Okay. You need the diagnosis by code and name. If any of you have ever gotten a record that just had the code for the diagnosis, you had to look up the name of the diagnosis. Most of us don't remember the names of every diagnosis there is when we see the code. And it gets annoying to have to look up those names. So don't annoy your reviewer. Put the code and the name. You need the presenting problem with the level of impact. I'm going to talk much more about that in a bit. You need the goals, objectives, and interventions. I'm going to talk about that. You need the progress, the plan, and the prognosis. And I'm going to talk about that, and also going to talk about the biopsychosocial stressors or the barriers to treatment. You need to include a risk assessment in a treatment plan, your medications with dosage, frequency, and prescriber, the modality, frequency, duration of treatment, and the conditions of discharge, and finally, why treatment is medically necessary. Anything that I have not talked about in any detail, I'm going to be talking about in detail. So don't freak out on me, okay? Keep your feet on the ground and keep breathing into your belly. All right. So the first thing we need is the diagnosis. Primary, secondary, tertiary. If there are 3, there may only be 1. There doesn't have to be 2 or 3. In fact, it's better for the client if there aren't. So you have the name, the ICD-10 code, and the severity. Now, the reason we need to put the severity is because we no longer have the GAF. Some of you may not remember what the GAF is, but the GAF is the Global Assessment of Functioning. And we used to need to put that in our 5-level multi-axle diagnostic system. If we put a GAF, in the GAF, we assigned a number. And if we put a GAF of 55 or less, we could pretty much be guaranteed that we would get authorization for weekly sessions. Well, we don't have that. And there's pros and cons to not having that. The cons is we can't kind of guarantee we get authorization for weekly sessions. The pro is we can be much more specific. And here's one of the places to be specific. Some diagnoses come with a rating scale, like major depressive disorder without psychotic symptoms, mild, moderate, marked, severe, or extreme. Okay. Here's more about the diagnosis. The symptoms must support the diagnosis. I have reviewed thousands of treatment plans and session notes. If the symptoms don't match the diagnosis, which I have seen a lot, like a therapist will diagnose depression, but all of the symptoms will be about anxiety. You're not treating depression. You have to treat what you say you're treating, or you have to document what you're actually treating. So the client must also have enough criteria to meet or to support the diagnosis. In other words, major depressive disorder has a number of criteria. You have to have a specific, at least a minimum number of criteria. The same for PTSD. In PTSD, I think there are like 4 or 5 categories, and you have to have a certain number in each category. And if you don't meet that number in each category, whether you agree with this or not, you can't diagnose PTSD. So make sure that you have symptoms that support the diagnosis and enough symptoms to support the diagnosis. You also need to have specific symptoms. So there must be specific criteria within the diagnosis to justify it. In other words, with depressed mood is a standalone symptom. You must have it. You must have hopelessness. And in PTSD, you must have witnessed or experienced a life-threatening or a perceived life-threatening event. Okay, now we're going to go on to defining the presenting problem. This is where we really get into the meat of the program, and I'm just going to, okay, I'm just checking my questions, and these questions are going to be answered. These questions are going to be answered later on. So if I don't answer them by the end, please ask them again. All right. Okay, thank you for bearing with me as I was checking the Q&A. So, how to define a presenting problem, the symptoms and the behaviors of a mental health issue for which a person seeks help. So we are going to use the diagnosis of major depressive disorder without psychotic symptoms, severe. We're going to use this diagnosis with a real client all the way through treatment plan, progress note, case and collateral, all the way through, right to the end. So major depressive disorder, severe. Here are some symptoms. Disordered sleep, somatic complaints, alexithymia, irritability, trouble focusing. And we, of course, we rated the level of impact, right? We're lucky. Major depressive disorder comes with its own rating scale. Okay, so here are the symptoms that I listed. But what symptoms are missing? Please write them in the chat. What symptoms are missing from the symptoms that I listed here? It always takes a moment for the, yes, depressed mood, duration, length of time. Yep. Mood or lack of interest. Very good. Okay, you got it. Depressed mood, hopelessness, length of time. Now, I will tell you, even as the documentation wizard, I can make mistakes. When I first put this PowerPoint together and I created this process that you're learning, and I was writing the symptoms for this client, I left out depressed mood, hopelessness, and length of time. And I decided to leave them out so that I could show you how easy it is to forget them, and that, you know, that's why you have somebody review your work if you're having an audit or you have to turn your notes over for any reason. All right, level of impact or severity. There are different ways to rate level of impact or severity. One is frequency. I'm going to back up just a moment. This is one of the harder things for clinicians to do. And it's difficult because it can be difficult to get the answers from the clients. So you can rate frequency. You can rate it as a percentage, daily, weekly, twice a week, 3 times a month. But, you know, have you ever tried asking a client, so you're having trouble sleeping. How often do you have trouble sleeping? Oh, a lot. Well, what does a lot mean to you? Oh, it happens all the time. Well, what's all the time? How many? So you have trouble falling asleep, right? Yeah. Well, how many times a week would you say you have trouble falling asleep? Oh, I don't know. Most of the time. You know, is the person going to be able to say, well, I have trouble falling asleep 3 out of 5 nights a week? Or not 3 out of 5, more like 5 out of 7. So if you can't get frequency, go for intensity. Is the problem mild, moderate, marked, or severe? And by the way, marked means when you're sitting with the client in the room or you're on video, you can see the distress. I'm sure that when we were able to sit in rooms with people, and I imagine some of you still are doing face-to-face or resumed some face-to-face sessions, but you know, you can see somebody going like this, or you can see somebody's leg going like that. That's marked. You can see it. And the duration. Has the problem been going on for a week, 3 months, 2 years, or, you know, since the client was 13? And it's unfortunate. There are a lot of people who have been depressed since their teen years, a lot of adults. All right. Now, how do we operationalize this? How do we take, this to this? We start with the diagnosis and the symptoms. We make sure the symptoms align with the diagnosis. We have enough of them, and we have the ones that are mandatory. And then we find out the behavioral examples of the symptoms. What does the symptom look like? How does the client behave that demonstrates this symptom? So, one of the diagnostic criteria for major depressive disorder is disordered sleep. Well, what kind of disordered sleep? It's not enough to just say disordered sleep. What kind of disordered sleep? This client has trouble falling asleep 5 out of 7 nights. He doesn't want to get up and in the morning and is often late for work. That's how disordered sleep shows up for him. This is specific. And I will tell you that insurance companies want the specifics. They want to know that you are diagnosing and creating a treatment plan for a person. You're not creating a treatment plan for a diagnosis. And disordered sleep can be trouble falling asleep, trouble staying asleep. It can be both. It can be having nightmares. So be specific about what the problem is. It also is more measurable that way. Somatic complaints. This client has somatic complaints. So this client has stomach aches and headaches multiple times a week. I asked, how often do you have stomach aches and headaches? Oh, a lot. Well, do you have them every day? No, not every day. Most days? A lot. So I put multiple times a week. Now, the reason I put no medical diagnosis is because I asked him, have you been to the doctor? Did you go and get any medical issues ruled out? And he said, yeah, there's no problem. They told me it's all in my head, something like that. All right. Alexithymia. He has significant trouble identifying and tolerating emotions. Now, the definition of alexithymia is difficulty identifying and tolerating emotions. The rating scale is significant. I mean, do I actually ask the client to take a check pad, a notepad, and check off how many times the person cannot identify their emotions? First of all, they can't identify their emotions, so they might not know. And second of all, it's kind of a ridiculous thing to ask. So significant. Irritability. So what does it look like for this client? This client is irritable at home and at work and weekly. In other words, often. And this client has a barrier. He has 2 of them, actually. His family is not supportive of him seeking help, and he's in danger of losing his job, partly because he's so argumentative. So barriers, and I'm going to go over them a little bit more in a little while. Barriers are not the symptoms. The barriers are external influences. They're what's happening inside the client or in the client's life. All right. So you do not have to be a CBT therapist in order to document behaviors. You can, it will help because CBT therapists think in behaviors, but anybody using any modality can document using behaviors, and that's what's necessary. here are a couple of questions you can ask. One is, what does the depression cause you to do or not do? So I like this question for a couple of reasons. One, it makes the depression the problem, not the person the problem. Two, it externalizes the problem. It makes the client go, start to self-observe. What does the depression make me do or make me not do? Now, sometimes clients can't answer that. And I'll address that in a minute. Here's another question. If someone was looking at your life as if it was a movie, what would they see you do or not do that would show you were depressed? I like this one because it externalizes it even further. It has the client start looking at themselves as in someone else's shoes. And so many of our clients come to therapy without the ability to self-observe. And one of the things we teach them is how to self-observe. I mean, you can't really do a lot of therapy without being able to observe your own behavior. So if someone says, well, no one would know I'm depressed. Well, why not? Well, I don't share my business with anybody. I'm sure a lot of you who have had that comment. So if they can't tell you what it makes them do or not do, and they can't tell you what other people think, then you start asking them questions, diagnostic type questions. And I know that you all already do this. I actually send my clients a 25-item symptom checklist that they by diagnosis, divided into several diagnoses. And so when I get that checklist back from them, I can use it to inform my interview. So why do we describe diagnostic criteria in behavioral terms? We do it because insurance companies require it, but we also do it because change shows up in behavior, and it therefore makes clinical sense. Clients want to know that they're changing. We want to know that they're changing. Kenneth, I can't answer your question right now. Which checklist do I use for screening? It's a checklist I developed. But I'm not gonna, it's a checklist I developed. All right. Now let's go, wait. So I want to just reiterate, you do not have to be a CBT therapist in order to document behavior. You can document it using any therapeutic modality. Okay. Now, what are the barriers? Well, the barriers are those TZ and TV and Z codes at the back of the DSM-5. They are the risk factors or the biopsychosocial stressors. They complicate treatment. It's kind of the system the client lives in, and it's what affects the client's life. Here are 8 of them: caring for an ill family member, coping with significant loss, sibling relational problems, parental mental health issues, domestic violence, divorcing parents, financial hardship, court involvement. Not only is there a list at the end of the DSM-5, I have a list of 60 of them. Some of them are that I made up. Some of them are codable. You can find them in the back of the DSM. Some of them are not codable. They don't have to be coded. They don't have to be coded because you don't bill for them, but they support medical necessity. They are often the things that people come in complaining about. All right, now we are going to get into the repetitive part of this presentation. So research shows that we learn best by repetition, and that's why this is so repetitive. You're going to see and hear the relationship between each element in a treatment plan. So first we have the diagnostic criteria with the presenting problem. Then we're going to have the presenting problem to the goals. The goals, we're going to show the relationship to the objectives, then the objectives to the interventions, and then we're going to show the relationship of progress to goals. All right, I think you're going to like this part. So, disordered sleep. The client has trouble falling asleep most nights and does not get up in the morning on time and is late for work 3 to 5 times a week. Somatic complaints. Client has stomach aches and headaches multiple times a week with no medical diagnosis. Alexithymia has significant trouble identifying and tolerating emotions, irritability, and socially isolated. The client argues weekly at home and at work and has few friends as a result. The barrier is that the client's family doesn't support help seeking and he could possibly lose his job. Now, what happens? The client has been trained. How does this show up as the presenting problem? The client doesn't ask for help. He's been trained not to ask for help. I am going to ask you, wait, let me check the timing here. Hold on. No, I am going to not ask you. I'm going to go right through and give you the definitions. I'll do asking later. All right, the definition of a goal. I call it the happy ever after ending of the story. If someone were to see you as if you were in a movie, what would they see you doing or not doing that would show you were depressed? If someone were to see you in a movie, what would they see? And things were better. It was the end of the movie, not the end of the life, but the end of the movie. And they were, what would they see you doing or not doing that would show you were not depressed? So put in really clinical or more clinical way is it's what the client wants to achieve. Where does the client want to go? What outcome does the client want to have? Goals are passive. They are a state of being. They are not what the client does. They're what the client wants. And they're in a treatment plan. Goals are general. They're not really specific. And it depends on for how long you write your treatment plan. I mean, if your treatment plan is every 3 months, you can have more specific goals. But if your goals, if you write a treatment plan for a year, you'll have more generalized goals. I really write them for the happy ever after ending of the story. Not even for a year. I want, what we're ultimately looking for. But if your agency says write them every 3 months, that's what you do, and you write them more specifically. Whoops. They can be written in the negative or the positive. Now, this sounds a little odd. Therapists are trained to write their notes Therapists are trained to think of goals as only in the positive. In other words, client will sleep through the night 5 out of 7 nights a week, or 7 out of 7 nights a week. But You can also write it in the negative. You can say, client will not have any sleep problems. Client will not struggle with falling asleep. The reason I say you can write it in the negative is because it distinguishes it from an objective. An objective is an action. It's what the client does to achieve the goal. And after we do goals, we're going to go through objectives. So just keep in mind that a goal can be written in the negative or the positive. And another thing is, if you ask a client, well, okay, so you're struggling, you're not sleeping through the night, most of the time. What do you want to have happen? What's your goal? And very often the client will say, I don't want to have a problem with sleep. So the client will language it in the negative. All right. If you ask a client what their goals are, here's some problem that they have that they're having trouble describing, and you ask them what their goals are, and they say, I just want to feel better. And it's our job to take this and come up with the goals. And here's a visual of what it will look like when we've finished writing our treatment plan. Your goals are what you're reaching for. Here's your problem, and here are the action steps you're taking to reach your goals. Now, I have a question that says, can you write happy ever after happy ever in your goals? Will that satisfy? No, that will not satisfy the insurance company. But I appreciate the question. Okay. Now we're going to show the relationship between presenting problem and goals. So if the client is trouble falling asleep most nights and have difficulty getting up 5 out of 7 days and is often late for work, I want to hear what your goals would be. So would you write those in the chat, please? While you're writing them in the chat, I'm going to answer a couple of questions in the Q&A. Learn relaxation skills to practice at bedtime. Great. All right. To develop health, create a sleep schedule, sleep hygiene, improve sleep hygiene. Great. Review sleep hygiene and pick 2 to try. Okay. The goal, review sleep hygiene and pick 2 to try. That is an objective. Pick 2 sleep hygiene options to try. That is something that you do. It's a great objective. Create a bedtime routine. Learn sleep hygiene. Okay. These are more in line with goals. Here's what's really in line with a goal. Improve sleep 5 out of 7 days a week. That's really the goal. Improve sleep 5 out of 7 days a week. Improve sleep hygiene steps. That's fine. Mint blue light. Mint blue light is really would be considered, use a mint blue light. That's an action. You're going to use this thing. Develop health, sleep hygiene, create sleep schedule. Yeah, good question, Renita. Are these goals or objectives? Some people wrote objectives, and some people wrote goals. Be on time to work. Yes, be on time to work. What is the client going to do to be on time to work is the objective. The goal is to be on time to work. Learn PMR to assist with falling asleep. Report decrease in difficulty from. This is good, but I would take out report, because a goal is not about reporting. A goal is simply about decreasing. You decrease, increase, eliminate, improve. Review sleep time ritual and pick a few. That is an objective. Reviewing the sleep schedule and discuss bedtime routine. That's an objective. Client will decrease the number of sleepless nights and begin showing up at work on time. Yes, that is a goal. Client will develop a bedtime routine to promote relaxation and improve sleep patterns. Great. Basically, what you're saying is, yes, develop routine, improve sleep patterns. Journaling 3 to 5 times before bedtime, recapping the day, is an objective. It is an action. It's not a goal. Reduce sleep difficulty by 50% is a goal. A way to remember a goal is that it's measurable. Great, Diane, thank you. Okay, I really appreciate everybody writing, including the ones who are writing objectives, because without you writing objectives, we're not going to have the ability to compare and contrast. Goal would be not to struggle with falling asleep and to be on time for work. Great. Begin improving sleep in small steps, one night at a time. Okay. Client will demonstrate improved sleep hygiene as evidenced by waking without difficulty. Yeah, because you've got a measurement in there. Easily fall asleep most nights and wake up on time. Okay. Improve sleep hygiene 4 out of 7 nights and show up 5 minutes early to work. Great. All right. What did I write? Client will get a full night's sleep 5 out of 7 nights a week. Wake up rested and on time and be on time for work daily. So that's what I wrote. You all wrote other things. This is my treatment plan. You're going to write yours. Can rarely identify emotions, has stomach aches and headaches multiple times a week with no medical diagnosis. Okay, what would be some goals for can rarely identify emotions and has stomach aches and headaches multiple times a week? Let's see it. Write them in the chat. If the problem is can rarely identify emotions, what is the goal? I'm asking specifically because I really want you to think about it. If I tell you all the time what the answer is, you're not going to learn as well. We'll be able to identify emotions at least once per session. Great goal. Client will identify emotions. I would quantify that a little bit more, like most of the time, or be able to identify emotions often, minimize stomach aches and headaches. Yes. And you might want to quantify what minimize means. Client will identify at least one emotion that they experience each day. Client will identify at least one emotion. That is an objective. It's what the client is going to do. It's a great objective, but it's an objective. Patient will try to recognize emotions once per day. All right. Client will learn to identify emotions, decrease somatic symptoms once per week. Okay. There we go. Let me get a few more. Increase daily identification of emotions and decrease stomach pain and headaches. Yes. Client will work on gaining awareness of different emotions and identify impact on physical and mental wellness. Yes, this is a goal because it's will work on gaining. That's the operative word here, gaining awareness and gaining the ability to identify the impact. The client will have no stomach aches and headaches. There you go. That's writing it in the negative. We'll be able to identify emotions when needed and reduce somatic complaints. Okay, let's take a look at what I wrote. We'll be able to identify his emotions most of the time and have no stomach aches and headaches. So here I wrote it in the positive, and here I wrote it in the negative. Whoops. Wait, what happened? There we go. Argumentative on a daily basis, socially isolated with few friends. What would be a goal? That he's argumentative on a weekly basis. Yes, you can say that goal is the destination and the objective is the vehicle. Absolutely. Thank you, Lara. Client can speak to his emotions in session. Client will become physically comfortable. Not sure about the physically comfortable piece. I don't quite get that. Decreased frequency of argumentativeness. Great. You might put in from what to what, patient will have no arguments with friends and coworkers weekly. Increase social contacts. Great. Will not argue with family and coworkers. Great. Okay. A client will reach out to a number of friends, acquaintances for conversation, social interaction. That is an objective. That is active. Will reach out. He will schedule and reach out. That's not a decrease. I know this is confusing, but keep in mind that goals are increase, decrease, gain, minimize, improve. Okay, what did I write? Will not be argumentative or socially isolated and will have friends. Do you see how the relationship is, what the relationship is? Argumentative on a weekly basis, and the goal is will not be argumentative. And if the client is socially isolated with few friends, the goal is to be, socially isolated and will have friends. Not be socially isolated. Even the wizard makes mistakes. I don't always catch things. Okay, not be socially isolated and will have friends, or reduce social isolation and increase friendships. Difficulty asking for help and at risk of being fired or losing job. What are the goals for difficulty asking for help? While you're writing, I'm going to answer Jason's question. Do we need to define socially isolated or having friends? That really depends on you and the client and how you conceptualize what's going on. And if the client knows right away at the beginning of writing the treatment plan, then you can have goals that are much more specific. But if you don't have any specifics, then you can be more general. Okay. Client will improve self-advocacy skills. I love that. Increase requests for help. Great. Will ask for help when needed on a daily basis. That actually, even though that is an action, I would let it pass. I'm going to be picky here, but that's what you want me to be. Client will be able to ask for help when needed on a daily basis. Now, if you were to write, client will ask for help on a daily basis in your treatment plan, you're not going to fail your treatment plan. Believe me, you're going to pass your treatment plan. Why I'm being picky is that I want you to understand the difference between active and passive, between goal and objective. Client will ask for help at home and work. Client will be able to. Client will increase ability to. Client will be able, there we go, when needed. Okay. Client will be able to ask for help when needed. Okay, we've got some repeats. Increase frequency of help and maintain current job. Great. Or increase frequency of asking for help and maintain current job. Ask for help is an objective. Client will ask for help. Be secure at the job is a goal. Increase frequency of asking for help. Client will learn how to ask for help and reduce the risk of being fired. Great. Okay, what did I write? Be able to ask for help, keep his job, or don't get fired from his job. It could be, I could say either keep job or don't get fired. This is the positive, this is the negative. So if there's difficulty asking for help, be able to ask for help or increase ability to ask for help. At risk of losing job, keep job. It's really very simple. It's just the goal is the problem from the perspective of the solution. All right, now we're coming to objectives. What is an objective? An objective is what the client does to achieve the goal. It's active. We use active action verbs. It is always written in the positive because you cannot not do something. You can barely say that sentence. You cannot not do something. All right, so goal. The client will get a full night's sleep 5 out of 7 nights a week, wake up rested, and be on time for work. What would an objective be? And while you're writing, okay, I can't answer the questions at this point. Why would a measurement be stated in the goal? A therapist will teach sleep hygiene. That's not an objective, that's an intervention. Anything that the therapist does is an intervention. We're going to see the relationship between objective and intervention right after we do this section. Here we go. We'll learn and practice relaxation exercises before bed. That is an objective. We'll do relaxation exercises 10 minutes before bedtime. That's an objective. Learn relaxation. I would say learn and practice relaxation strategies. Practice grounding exercises daily before bedtime. We'll practice PMR prior to bedtime. Somebody tell me what PMR is so that I know. Develop a sleep schedule and learn sleep hygiene to improve sleep. I really like develop a sleep schedule and improve sleep hygiene because it's more general. It and treat objectives in and goals in treatment plans are generally more general. We save the specifics for the session note. Client will develop and implement a sleep routine 5 out of 7 nights a week. Yeah, great. We'll reduce screen exposure 1 hour before bedtime. Now, that's really a good one. It is very specific. So you might want to leave that one for the session note when you really get into the weeds about what's affecting the client's sleep. However, if you already know right at the beginning that the client is on screens right before going to bed, then of course include it. There are no hard and fast rules about that piece of it. Using the sleep hygiene plan, client will maintain a sleep journal showing an increase in reported sleep. Great. Client will develop and use at least 3 relaxation strategies to assist with improved sleep. That's a great objective. Use at least 3 relaxation strategies. What did I write? Client will identify what interferes with sleep. Engage in sleep hygiene, get up and get to work on time. I made it really say, get up, get to work on time. I wasn't like that in session. But what I realized in our conversation is that he didn't know what interfered with his sleep. He didn't have a clue. When I asked, well, do you know why you have a problem with sleep? And he says, I don't know. So we had to first start with identifying what the problems were. But do you see, get a full night's sleep 5 out of 7 nights a week, that this relates to that, and engage in sleep hygiene, and that get up and get to work on time relates to wake up rested, be on time for work? I want you to see the relationship. That's the golden thread. We'll be able to identify his emotions most of the time with no stomach aches and headaches. I'm just going to tell you what I wrote. Identify the relationship between emotion and physical problems, identify, reframe cognitive distortions, and learn and use mind-body techniques. That's not, never mind about what it's not. So you see, we'll be able to identify his emotions most of the time, identify the relationship between emotions and physical problems, because he's got stomach aches and headaches. So he's kind of got to get the relationship between the emotions and the physical stuff. And he has some cognitive distortions around all of this. And so he's got to learn and use mind-body techniques. Not saying which specific mind-body techniques. If I talk about specifics, then I'm kind of locked into specific mind-body techniques. What if the ones I write don't work, or he doesn't like them? So I just write mind-body techniques. I might get consultation to find out new ones. Okay, will not be argumentative, socially isolated, and will have friends. I'm going to tell you what I wrote because I want to make sure that we get to have our break soon, and in the good timing, we get through enough. So the client is going to identify the triggers to anger. So he will not be argumentative. Identify triggers to anger. And he's socially isolated with few friends. Identify the barriers to having friends and being socially engaged. Now, you might write this very differently. This is your client. When you're writing it, it's your client and your treatment plan. This is what I wrote. I just want you to see the relationship. Will be able to ask for help, will keep his job. Learn and practice good communication skills at home and work, and ask for help. That's the objective. Here is the visual. This is the difference between goals and objectives. The goals are like the umbrella. You have your problem and you have to take action. These objectives are the action that you take. It's like pushing up that handle on the umbrella. This is the handle you push up, the action you take to reach the goals or open the umbrella. Now, this is a nice, pretty picture of a goal and objectives, right? And the problem. That's a nice, pretty picture, what it's all going to kind of look like when you write it. This is what it's like when you're doing it. I just want to acknowledge that it is not a linear process. All right, now let's compare objectives to interventions. If the client is going to identify what interferes with sleep and engage in sleep hygiene and get to work on time, I want you to see the interventions. If the client is going to identify what interferes with his sleep, then the therapist is going to help client identify what interferes with sleep. If the client is going to engage in sleep hygiene, the therapist is going to teach sleep hygiene and process feelings about work and strategize getting to work on time. If the client is going to get up and get to work on time, the therapist is going to help the client do that by strategizing and identifying feelings. You could have also written in here, client will identify and process feelings around getting to work on time and strategize getting to work on time. And then this would really make sense and really be a one-on-one relationship, identify and process feelings about work. Identify relationship between emotion and physical problems, identify and reframe cognitive distortions, and learn and use mind-body techniques. Okay, so if the client is going to identify the relationship between emotion and physical problems, the therapist is going to provide psychoed on the relationship between unprocessed emotion and physical problems. And if the client is going to identify and reframe cognitive distortions, the therapist is going to help the identify and reframe cognitive distortions. And if the client is going to learn and use mind-body techniques, the therapist is going to teach mind-body techniques. What I really want you to see is the one-on-one relationship. Here's a few more so that you can see it. Identify triggers to anger and barriers to being socially engaged. So, intervention, help identify triggers to anger and barriers to being socially engaged. Do you see, you don't have to spend a lot of time writing up you don't have to go to a treatment planning book and say, what interventions do we use for this problem, for anger? You could include something about anger management. Client will engage in practicing learning. Client will learn and practice anger management skills. Therapist will teach and help client use anger management skills. Learn, practice good communication skills, and ask for help. Teach and provide feedback on communication skills. And I added model appropriate behavior. Okay. And then also conduct standardized assessments. Insurance companies want standardized assessments more and more. They're relying on them a lot. So if you are going to conduct a standardized assessment, which I did not do on this client because it was before they were required, then an objective would be to take standardized assessment. And a good standardized assessment to start out with is the Schwartz Outcome Scale, or the SOS. It's a 10-question quality of life assessment. It's a 6-point scale with 10 questions. And it's a really good one to start off on. I have a list of over 60 of them, free diagnostic, free standardized assessments that you can get online. All right. Now we're going to relate goal to progress. So if the client has trouble falling asleep most nights and difficulty getting up 5 out of 7 days and is often late for work, then what is the progress this client has made? Well, this client falls asleep easily 2 out of 3 nights a week. He recognizes how sleep and eating habits affect his depression. And he gets to work on time 4 out of 5 mornings. Now, nowhere in this treatment plan did anything come up about food, right? But what we learned in our work together was that he drank coffee late at night, which is one of the things that kept him up. And it made him too jittery to fall asleep. And the lack of sleep increased his depression. So even though this was not mentioned anywhere in the treatment plan, I mention it in the progress because it's real progress. I'm sorry, Rebecca, I cannot share the link. I'll talk about, you can go to my website if you want information about that. Goal. Will be able to identify his emotions most of the time, have no stomach aches and headaches. This guy understands the connection between emotion and physical problems. He's occasionally able to identify and reframe cognitive distortions, and he can engage in mind-body exercises in session, but not on his own. This is very specific. That's what I want you to see about how progress should be documented. Will not be socially isolated, argumentative, socially isolated, and will have friends. The client can sometimes recognize triggers to anger, and he identified 2 people he might want to spend time with. And if the goal was be able to ask for help, and he will keep his job. He is occasionally able to ask for help, has kept his job. So far, at the time of this writing. And if I had done a depression inventory on him, I would have included the rating scale. Now, you saw this earlier. Does this make more sense to you? That when you have a problem, it needs to show up in every area. And I do want to see people say yes or no. Yes. Okay. All right. Excellent. Fabulous. All right. I do not understand what the ABCD stands for. This is a problem. This is a problem, this is a problem, and this is a problem. That's what they stand for. This is a presenting problem. Each one of these is a presenting problem. Major depressive disorder, as evidenced by difficulty falling and staying asleep 5 nights out of 7. Okay, that's one example. but we're going to move on to a risk assessment. So treatment plans need risk assessments. So there's either no risk or the client is at risk for suicide, homicide, assault, violence, or something else. Now, what is mandatory, legally required, is suicide, homicide, assault, or violence. Those have to be documented. I include other because we all know that people are at risk for cutting, binging, restricting, relapse of drugs or alcohol, compulsive sex, compulsive gambling, all kinds of risks. Those help justify medical necessity, but they're not required. You need to document whether there's an ideation, plan, intent, means, and access, and then whether the risk is low, medium, or moderate, or high. And if it's high, you need a safety plan. Now, very often at this point in the workshop, I get questions specifically about someone's client and assessing for suicide. And I am going to say, if you have anybody like that, please, there's no time for consultation here. That's not what this workshop is about anyway. Please take a suicide assessment or a risk assessment workshop or a few. I've taken 2. It will help you tremendously. You also even want to think about it, another possible risk is if a client is not sleeping well, is the client chronically tired, and would the client be a risk at the wheel driving to or from work, if we ever drive to and from work again? So you want to make sure that you identify those issues as well. And then if, again, high risk, a safety plan and how you're going to address it. And then what was the client's response? All right. Modality, frequency, and duration. So are you going to see the client individually? Are you going to be doing family or couples work? Are you going to do a family consultation or a case consultation? And are you going to be keeping up with the client's meds and what meds the client are taking? Now, if the client is on meds, this is mandatory. You have to keep up with it. And if you're seeing the client, are you seeing the client weekly, bi-weekly, monthly, or as needed? Now, bi-weekly can mean every other week or twice a week. If you are seeing the client PRN, please make sure that the client is stable, because you don't want to be have your license at risk if the client isn't stable and is only seeing you when the client feels like it. Duration. This is one that makes therapists very anxious. How do I know how long therapy is going to last? Well, some therapists really do short-term work. 3 to 9 months is really short-term work. I think even a year is pretty short-term work. If you have a trauma case, you know it's going to go on for 18 to 24 months, at least 2 years, because it takes 1 year just to get to the point where you can start working on just to make the safe space to address the trauma. So what the insurance companies want to know is that they're not paying for a best friend. It doesn't mean that clients shouldn't have a paid best friend. I worked with a client in the clinic who had schizoaffective disorder, and he needed somebody to be with him every night at dinner time because the voice that came to him every day came to him at dinner time, and it said, "Kill yourself." It's not a pleasant thing to listen to. So when he had company, that voice was much quieter. Now, the reason the voice was there was because the voice was trying to keep him company. So we got him company, but it can't be us to be the paid best friend. All right. Medications. We need the name of the medication, the dosage and the frequency, and the name of the prescriber. I like having this on the treatment plan because when I review the treatment plan, I remember to check the meds, and I have all the information I need in case, like right at my fingertips, in case I need to contact the prescriber. Okay. Prognosis. Oh, this is a new one. Recently, maybe it's not new, but it's new to me. I recently found out that Medicare wants prognosis, and I think that it's new. Now, prognosis means given the client's age, health, access to care, economic, social and economic status, issues around diversity, mental health history, their engagement and motivation. What are the chances of the client reaching their goals? Prognosis actually makes a lot of sense around medical issues. Like, what's the prognosis for a person with congestive heart failure? What's the prognosis for a person with cancer? Because medical professionals have concrete ways to assess. Mental health is a lot harder to assess, and I don't actually agree with the prognosis requirement, but we have it. If you want to know more about it, go to my website and look at the blog. I think it's the last blog that I wrote on how to assess prognosis. What I do is I write something like, given clients' history, supports, and motivation and engagement, reported in the diagnostic assessment or shown during treatment, client's prognosis is, and then I rate it as a 1 to 5 scale, 1 being poor, 5 being excellent. But you can use, poor, moderate, etc. So I know it's difficult to do, but we got to do it. We also need conditions for discharge and follow-up recommendations. So, what are the conditions for discharge? The conditions for discharge, I always write when long-term goals are met. You can also write other. I'm not exactly sure what other conditions would be, but I always say when long-term goals are met. And actually, this part, client will re-engage in treatment if and when needed and wanted, that actually belongs on the discharge summary. Does not belong on the treatment plan for conditions for discharge. So just put a big X through those. I am sorry. I was redoing this the other night, and I must have made a mistake. I wrote it on the wrong screen. Okay, here is medical necessity. We just had our hypothesis, which is the diagnosis of major depressive disorder severe. Everything else was the supporting evidence. And here is medical necessity. Continued treatment is medically necessary too. Now, at the beginning of treatment, I always start with address symptoms, reduce symptoms, and improve functioning. Partway into the treatment, I don't know when that's going to be. I might stop addressing symptoms. I might stop learning about how they manifest, and I might move on to reducing them or continue to reduce symptoms, improve functioning. I might be stabilizing symptoms. I might be, there's also maintaining gains. If the client was in really bad shape when they first came, you might want to include prevent decompensation or prevent a higher level of care. You can have multiple ones, and each time you do a new treatment plan, you can change it. I will also say that sometimes you address symptoms for major depressive disorder, and you kind of work through all of that stuff, and the client is functioning pretty well in terms of depression, but what now has surfaced is anxiety. So then you're back to addressing symptoms. So again, there is no hard and fast rule. It's all about your treatment. Jason, I am sorry, I'm not quite sure which forms you are talking about or addressing, but I sure understand dealing with two toddlers having tantrums, and I feel for you. All right. What we're going to do now is you're going to watch a video of me being interviewed by Liz Brenner, who is the Director of Therapy Training Boston. This is a 12-minute interview, and you are going to go to the back of your book and take out this page. And you're going to practice writing a treatment plan based on this interview. This is a practice form. It does not have everything you need for a treatment plan. It has what you need to create the golden thread. It's missing a lot of the other details. And then we're going to review it after you write it. Okay. So, Therapy Training Boston, by the way, is an organization, obviously it's in Boston. Liz puts on lots of trainings, about 10 trainings per year from some of the brightest and the best. And I have had the absolute privilege of training for her like 3 times. All right, so here is the interview. And this is an interview of Liz, of me, before I let my hair go gray during the pandemic. And she is interviewing a therapist who is very anxious about how to write her notes. So here we go.
So let's introduce ourselves. So I'm Liz Brenner. I'm the Director of Therapy Training Boston. And this is Beth Rontel.
And I am a therapist. Hold on one second. Someone says, where's the forms, please? The forms should be at the back of your book. Okay. And on top, it says treatment plan practice. All right, here we.
So let's introduce ourselves. So I'm Liz Brenner. I'm the Director of Therapy Training Boston. And this is Beth Rontel.
And I am a therapist and teach clinical documentation.
So we're going to demonstrate an interview where I use solution-oriented and other kinds of family systems-oriented questions to interview Beth about a time when she struggled doing her documentation before she learned how to master it and teach it to people. And with the idea that we want to show you that in about 10 minutes, we're going to get enough information to integrate what she's struggling with and defining what we want to work on in her treatment with how she's going to be able to write treatment notes and treatment plans without a whole lot of hassle. So Beth, let's turn the clock back over a decade ago to when you were struggling with doing your documentation. And let's pretend that you came to see me as a therapist at that moment in time with your struggles, and we'll do an interview to see if I can help you.
I don't understand how to do this, and this all the notes, the progress notes they call them, and the treatment plans, I just don't understand, and I'm afraid that if I don't get it done, you know I work at an agency, right?
Mm-hmm.
If I don't get it done and I don't get it done right and I don't learn it soon, then I'll lose my job.
So you're worried about losing your job because you're struggling so much with your getting your documentation done, and you feel like you don't know how to do it. Is that right?
Yeah. And
And
it's just, I worry about it all the time.
so you're worrying about it all the time. So what happens when you're worrying?
I wake up thinking about it, I go to bed thinking about it, I'm not sleeping well. Since I don't really, I mean, if I understood it, I could just do it, but I don't really know what is expected, even though, you know, there's this kind of this format that they gave me. I don't really understand what's expected, and if I did, I think I'd be able to do it. But right now it doesn't seem to make any, there's no connection
Mhm.
between what I'm doing in the session and what I'm supposed to write.
So you can't figure out based on what you're doing with your clients how to complete the documentation.
Yeah.
And you don't really know what they're looking for.
Right.
How is the anxiety affecting your ability to do the documentation and to learn how to do it, would you say?
I think I procrastinate.
It makes
Yeah.
so you end up like not doing it.
Yeah, I mean, I put it all off until Sunday
Mhm.
because it has to be turned in on Monday.
Okay.
So then I have to spend hours and hours and hours doing it.
So what are the things that are getting in the way of you being able to do better with this?
Really understanding what's expected. Really understanding why I have to include certain things
Mm-hmm.
because it doesn't make sense. So I don't, you know, if I don't understand how to think about it, I can't make the connection.
Have you, in other situations, have you been able to learn things that have been hard?
Yeah,
So
Sure. I go through school.
what's getting in the way of you learning things that are hard in this context?
I think I could have used some more concrete support.
Mm-hmm.
I could have used having some examples.
So you're feeling like you're missing support.
Yeah.
And in the past, when you've been able to learn things that were hard, what supported your ability to do that?
Having somebody who I could go to and ask my questions.
Mm-hmm. So what's an example of how that happened in another context? Like, how did you find somebody who you could go to and ask questions?
It depended
So
on.
give me an example of a time when you had to learn something that was hard and you actually did seek and find support.
I would just keep asking people who might have information about the topic that
Uh-huh.
that I had to deal with,
Mm-hmm.
the issue, and
And
then
what's an example of that?
when I would struggle with how to use a computer, I would ask my
Uh-huh.
husband.
Yeah.
He's really good at it,
Okay.
and I would say, "Can you just please just explain the context and explain the details
Yeah.
so that I can understand."
So far in your agency, you haven't felt like you've gotten that support and you haven't found a way to get it elsewhere. Is that right?
Yeah.
Yeah. Okay. So what are your intentions for yourself with regard to managing this issue of struggling to get your documentation done and the way that it's affecting your life with anxiety? And
My intentions. My intentions are to do it, to do it well,
mm-hmm.
to be able to get it done quickly and easily, and right, because I don't want to have it turned back to me. I don't want to have to worry that I have to have a telephone review to justify my work.
Mm-hmm.
I don't want to have to go through an audit and be responsible for the agency losing money.
So your goal or your intention for yourself is to be able to learn how to do it right.
Yeah.
And what about with the anxiety? What's your intention with that?
Oh, to not have it.
Mm-hmm.
To not, to not have it keep me up at night, to not have it wake me up, to not have stomach aches, to not procrastinate, to just be able to sit down and do it because it's not a horrible challenge.
So does it make sense to focus on the anxiety first? Is the anxiety getting in the way of learning and doing the paperwork?
Yes.
Okay. So if we focus on the anxiety for a minute, if 0 is you're so incapacitated by anxiety that you can't do anything or seek out support, or even make an attempt to do your paperwork, and 10 is you're not feeling much anxiety and you're able to do your paperwork and seek out support, where would you say you are now?
Right now, I would say I'm about a 3.
Okay. So what do you think it would take to move in the next few weeks or so to move yourself up from a 3 to a 4?
What would it take? To reduce the anxiety? I'm not sure how to answer that.
Mm-hmm.
I think one of the things I would need is a clear understanding of what needs to be written.
So do you have any ideas about how you could find that out? How you could get
Well,
that?
maybe there's somebody at work who might be able to help me,
Mhm.
sit down with me and be willing to
Mhm.
take the time to do that.
So are you thinking you might try to ask somebody at work if they have the time?
Yeah. I mean, there are other therapists there who have been there longer than me. Maybe they
Mhm.
know.
Mm-hmm. Okay, great. So you're thinking if you get a little bit of helpful information from somebody and support that it might reduce your anxiety?
Yeah.
And, okay.
Yeah, and I guess I need to remember that, I'm not my work. I'm not a terrible person if I'm struggling.
Oh, so that the struggle at work is making you feel like a bad person?
Oh, God,
Oh,
yeah.
okay. So you have, it sounds like you have another goal for yourself, which is to try to separate the dilemma at work from who you are as a person. Yeah. Okay, great. So have you, that ability, did I already ask you, have you had that ability to seek out support in other situations?
Yeah,
Okay, so you have been able to do that.
yeah.
Okay.
Yeah, I'm able to do that.
Yeah.
I mean,
Okay.
I'm able to do that.
And what might get in the way of you taking that step?
Well, at work, I think I need to be careful who I ask
Mhm.
because you don't want it to get around that you don't know what you're doing.
So you want to make sure that, so one barrier might be figuring out who to ask that would be a safe person
Yeah.
who could help you and not make you look
and
bad.
not make me look bad or make
Yeah.
me feel bad.
Yeah.
I already
Okay.
feel bad.
Yeah. Great. So what do you hope for yourself in the future with regard to this dilemma of struggling to get your paperwork done and not knowing and feeling anxious and feeling like a bad person related to it?
Well, I want to master it. I
Mhm.
just don't want it to get the better of me anymore. I want to be able to do it easily, do it quickly, not procrastinate, be done with it at the end of my day, and feel good about it. And actually, it would be really nice if I felt like the time I spent doing it wasn't a waste of time.
Mm-hmm. So it sounds like you want to figure out how to do the paperwork in a way with more ease and also in a way that felt like it was productive, not just some annoying exercise.
Yes.
Is that right? Okay.
Yes.
Sounds good. So do you think we've covered this in terms of what we would need to write a treatment plan for the younger Beth who didn't know how to do this?
I think so.
Yeah, okay.
Yeah.
Great.
All right. So let's write our treatment plan together. So what is the diagnosis? And you can put it in the chat. Anxiety, yep, but what kind of anxiety? Generalized anxiety. Okay, let's be specific. Paula, you put work. Some people, a lot of people think it's generalized, moderate, adjustment disorder with anxiety, adjustment disorder with anxiety. Okay. All right. Well, I will tell you that some people actually think this is PTSD because they relate to it so much. Performance anxiety. Okay, well, performance, Jennifer, yeah, there is some performance anxiety related to this, but I want to be clear that you actually need the mental health diagnosis, and performance anxiety is not a mental health diagnosis. That would be one of the behavioral examples, or one of the, not one of the behavioral, yeah, that would be one of the behavioral examples. It needs to be some kind of anxiety related disorder, because she is coming to therapy saying, I'm really worried about my job. I'm having trouble with this specific issue. I would say that for the purposes of this process, that we will diagnose her with adjustment disorder with anxiety. If you knew her a little bit better, you would know that there's some anxiety that's pretty pervasive, but you don't know her any better. So those of you who think it's generalized, you're picking up in a time of this person's life where it really was quite generalized. Stress and adjustment disorder is not the diagnosis. Generalized anxiety disorder with, not generalized, adjustment disorder with anxiety, or with anxiety and depression. Okay. If you were to work with this client for more than 6 months or 4 months, and the anxiety around this issue did not clear up, then you would re-diagnose her with generalized anxiety disorder. So yeah, Renita, you're right. It did sound like her anxiety is pervasive, but you would have needed more information. Okay. What is the criteria for generalized? What is the criteria for adjustment disorder with anxiety? Well, this is where your DSM-5 becomes your best friend. So you would actually want to go to the DSM-5 and take a look under the section for anxiety. And you would see that there were criteria. Some of you guys write the criteria, put it in the chat. You guys, I'm sorry if I'm saying you guys. I know that I'm trying to change my language from you guys to you folks. I'm struggling here. So know that I'm engaged in the struggle. So what's the criteria? Recent change, good. Response to stressor, yep. Onset, I think within 6 months, yep. Experiencing more stress than is justified or that is expected. Symptoms cause distress. And what are the symptoms? Because we have to have the symptoms. Because without the symptoms, we don't have the behaviors. Problem sleeping, I cannot see half the yes. Anyone who is responding just to me, please change your answers to all participants so everyone can read it. Yes, sleep difficulty, lack of sleep, stomach aches, headaches. Great. Okay, so the symptoms for anxiety are excessive worry, more days than not, somatic complaints, lots of somatic complaints, an exaggerated startle response to minor stimuli, difficulty concentrating, mind going blank, persistent irritability, difficulty getting to sleep because of the worry. All right. The stress-related disturbance does not meet criteria for other mental disorder. Great. Great. You don't have to write all of that piece that the stress-related disturbance does not meet criteria. All you have to do is write what it does do. But I'm glad that you're looking at it thoroughly. Okay, so now we have the general symptoms. What are the behavioral examples? If someone were to see her life as a movie, what would they see her do or not do that would show that she's anxious related to this stressor? Or what does this job issue cause her to do or not do? What does the anxiety cause her to not do or not do? Yes, problems getting work done, worry, specific somatic concerns. What are the somatic concerns? Let's be clear. Let's be specific. Procrastination, avoidance of completing notes. Now, procrastination and avoidance are really the same thing, right? Whichever one you write is fine. One person writes procrastination, another person writes avoidance. Not a problem. Sleep disturbance, trouble waking up, procrastinating, not completing documentation, difficulty sleeping, right? Socially isolated. It's a little different than socially isolated. She doesn't know who to ask for help. She has stomach aches. That's becoming more specific about the somatic issues. Great, good, Jason, good clarification. I don't think she said that she has hot or cold chills. That is a symptom of anxiety, but she does not say that she has hot or cold chills. She does not ask for help because she's worried about it. Ruminating thoughts, very good. Issues with self-image. Yeah, she thinks she's a bad person. Right. She confuses her work and her professional and her personal, she conflates her personal and professional life. Restlessness, fear of being audited, peer or supervisor review. Yeah. I'm not quite sure what you mean by daily stress, but daily stress is not specific enough. Yeah, she's worried about what others might think or say. That is specific. Okay, here is what I wrote. Adjustment disorder with anxiety as evidenced by excessive worry about job performance and concern about losing her job. So notice that I included right away what the stressor is, what she is adjusting to. Does not understand expectations, worried about being negatively judged by colleagues for lack of skill in this area, difficulty falling asleep due to ruminations and wakes up ruminating, difficulty focusing and concentrating, mind goes blank because of anxiety, procrastinates, cognitive distortions, quote, I am a bad person because of my job performance, or negative self-concept because of struggle with job, conflates self-worth with job performance. This is very specific. Now you have something that you can work on and see whether the client is making progress or not. Now, how do I know that the insurance companies want it to be specific? I will tell you. In case you were worried that I wouldn't, I will tell you. When I was training for Therapy Training Boston, the very first training I did, there were like 48 people participating. And about the second or third row from the back were 4 UBH reviewers, United Behavioral Health reviewers, sitting in the back. And I will tell you, this was quite a number of years ago, and I was not as confident in my presenting skills as I am now, although I was confident in my work. But I said, and insurance companies want specifics. They don't want a treatment plan written for a diagnosis. They want it for the specific client that you're working with. And I looked at him and I went like this inside. I'm like, oh my God, oh my God. And I look at him, am I right? And I tell you, each one of them in unison went like this. It was like a wave in the ocean. Yes, you are right. So I am sure they want it to be specific. All right, so you just got specifics of the presenting problem. What are the barriers? Write your answers to the barriers. So while you're writing your answers, I will answer or respond to one of the questions. Yes, you can have my write-up. Later on, near the end, put your email address in the chat, and I will make sure that whoever leaves me their email address gets my write-up. Okay? No problem. No support from clinical staff or supervisor. You nailed it. Not sure who to ask for help. Not sure who to ask for help is inside. I'm not sure who to ask. No support from clinical staff or supervisor is outside. That's the context. That's the circumstances she operates in. And that was true, by the way. Fear of what others think if she, the fear of judgment, not knowing who to ask, unsure who to go to for help, that's a symptom or that's a behavior. Not being trained is the barrier. Not having a supportive supervisor is the context or the barrier. Not sure who to safely ask for help is a behavior, is a behavior demonstrating a symptom. Okay. Martha, please put your email, and Dorothy, anybody who's giving me emails, please put your emails in at the end. It'll make it so much easier for me to separate it all out. Otherwise, it's going to take me hours to separate this and get you what you want. Fear of poor outcome from asking is part of the problem. It's not from the inside. It's not a barrier. It's not what she works, the system in which she works. No peer support. That's the system. Okay. Has not identified who to ask for help, you ask? No, that's part of the problem that comes from inside her. No peer support is what is a systemic problem in the agency. Great. No peer review. It's about something else. All right. By the way, I want to just reiterate something, not reiterate, say that this problem that you were writing about is systemic when you go to an agency. I don't know about you, but when I went to the clinic where I eventually became a supervisor, here's what my supervisor said to me. Oh, you want to know what the paperwork is? Let me tell you what the paperwork is. And you want to know how to do it? Let me show you. And he took me over to a wall that had a whole bunch of little cubbies on it. And he started pulling out the paperwork from all the cubbies, right? He says, this is the paperwork you do on the first session. And I went, okay. He says, read it over. That was the training I got. How to write a treatment plan, how to write a session note, how to do an informed consent. That was my training. And I am sure that that was the training for most of you. Okay, there is an interesting question here. Many of these systemic issues may wind up being related to her assessment of the situation. In other words, anxiety clouding her view. How do you capture that in the long run? You say that. You say that. In the barriers, you can say no training and lack of supportive supervisor increases anxiety. Okay, constant worry, not sleeping well, anxiety, procrastination, lack of understanding the documentation process. Those are the behaviors related to the symptoms. They're not the barriers, but they're a great description of the behaviors. Lack of structure and agency for due diligence, for documentation and training. Beautiful. Great. What did I write as the behavior? Reports receiving no training and has no identified supports. No training, no supports. That's how I wrote it. This is how you wrote it. Okay. Now, the goals. What are her goals? Yes, Jason. Barriers would include the biopsychosocial information. It could include the biopsychosocial information. In this situation, it is the lack of training and support. Yes, Brenda, very good. You can even put it in quotes. I want to master the documentation process. So if you later discover that what you thought was a systemic issue is actually her clouded view, how do you capture this change in your understanding of the problem? You write it in your assessment in the progress or the session note. That's it. And you update it in your next treatment plan. And you note that in the progress of your next treatment plan. Client identified, recognized that her understanding of the problem was, has a new understanding of the problem, something like that, or a more realistic understanding of the problem. Okay. Yes, the goal is to increase the knowledge of the documentation process. I want to do my documentation well, quickly, and accurately. Yes. increase documentation competency level, decrease symptoms of anxiety, right, decrease difficulty falling and staying asleep, decrease daily ruminations, be able to ask for help, keep job, increase comfort and understanding with documentation. You got it. You got it. Well done. Decrease, increase, do it in a timely manner without feeling like it's a waste of time. Yeah. Be able to ask for help, keep job, increase comfort level, increase understanding. Well done. All right, here's what I wrote. Be able to do her documentation effectively and efficiently, master the documentation process, improve focus and concentration, mind will not go blank. You don't have to write both of them. I just wrote both of them because I'm kind of covering the bases for you all. Stop procrastinating or get documentation done in a timely manner. Have documentation be meaningful and not meaningless. Stop conflating self-worth with job performance. Improve self-concept. Stop thinking she's a bad person because she struggles with her work. No longer worry that she will lose her job as a result of poor performance. This is what I wrote. What you all wrote is what you wrote. Most of what you wrote was right on the money. You just said it differently. You don't have to say it like I say it because it's your treatment plan. Be able to communicate needs for further training. Beautiful, beautiful. All right, objectives. What is she going to do? What did they decide that she would do? Or what are you going to do as part of your plan? Ask others for help. Yep. Identify a peer or supervisor to ask for help. Seek out additional supports. Yep. Great. I am going to read you mine. I love what you're doing. Identify a safe and a safe and knowledgeable person. All right. Here are my objectives. Identify a knowledgeable and trustworthy person and ask for help. Take a workshop on documentation. Identify, challenge, and reframe cognitive distortions, or identify and relieve burdens client carries about not being a good person. How you write this, I want you to see how you write this depends on the therapeutic modalities you use. Identifying burdens is an internal family systems language. Identifying, challenging, and reframing cognitive distortions is CBT. Find avenues for self-care like mindfulness and massage. Great. Engage in mind-body techniques to help relieve symptoms. Seek feedback on performance and get clarity on job performance and security. All right. Now, what are the interventions? Great, Stacy, beautiful ones. What are the interventions? While you're writing a couple of interventions, I will tell you that during lunch, I will do my best to answer the Q&As that have come in. Client will ask others for interventions, psychoed, good. Role playing, asking coworkers for help, beautiful. Seek out specific training. Are you, this is a therapist, going to seek out specific training, or are you going to help her identify specific training? Assist client with creating a plan to identify a safe and knowledgeable person. Yes, we'll practice asking for help with client during session. In other words, role play. Help her identify ... Beautiful. Okay, here's what I wrote. Help client identify a safe and knowledgeable person for help with documentation. Recommend documentation training. I want you to see how the Intervention can directly reflect the objective. If the client is going to identify a knowledgeable and trustworthy person and ask for help and take a workshop on documentation, the therapist is going to help the client identify a safe and knowledgeable person to ask for help and perhaps recommend a documentation training. And we'll go on. Encourage client to seek appropriate feedback about job performance. Provide mind-body techniques to help relieve symptoms. Help client process cognitive distortions about self-concept, or help client identify and process the parts of her personality that think she's a bad person. Okay, now what is the progress? I'm going to tell you the progress, because even though this is a first treatment plan, there is progress. And although in a first treatment plan, we do not have to identify progress, there was. And I like to identify progress wherever there is progress, because, you know, there's so few opportunities to celebrate, right? As a therapist. So the progress, the client presented as hopeless at the beginning of the session and hopeful by the end, and the therapist and the client co-created a treatment plan. That's progress. All right. And what's the condition for discharge? Okay, here's what I would say. When long-term goals are met, or when client reports significant reduction in anxiety with no functional impairments, or demonstrates competence with work, no longer worried about losing her job, no longer conflates self-worth with job performance. Those would be conditions for discharge. Yeah, when all goals are met. And prognosis, what would you say her prognosis is and why? And actually, just because of time, I'm going to tell you why. I'm going to tell you. I think her prognosis is a 4 or a 5. I'll get to that in a second. Yeah, thank you, Brenda. I would say it's a 5. Very good AEB past history. All right, as evidenced by past history. Yes, as evidenced by past history, motivation, engagement, progress during initial session. You know, prognosis is a 5. And it was. Here I am teaching. Okay. And medical necessity. Why is treatment medically necessary? What are you going to do? You're going to address, reduce symptoms, and improve functioning, right? That's at least at the beginning. If treatment goes on more than 6 months, which it really shouldn't, if this is all there is, you're going to change the diagnosis and you're going to do other things. You're going to stabilize some things, and you're going to maintain gains for some things, and you're going to improve functioning at other things. That is your treatment plan. All right. At this point, oh, geez.
So let's introduce ourselves. So I'm Liz.
There we go. At this point in the program, I'm often asked, do I need a treatment planning book? There are pros and cons to treatment planning books. I am not a big fan of them. I tried using them when I first started, and I found them very confusing. Some people really love them. I think they're really good under certain circumstances. One, when you're first starting out as a therapist, you often don't know that what you're doing is actually therapy. You're often using the therapeutic techniques that your therapist used with you if you were smart enough to be in therapy, to become, as you were becoming a therapist, or you're using the techniques that you learned in your program, but you don't have a really good grasp of what they are. Go to a treatment planning book, learn some good language, but make sure it corresponds with what you're actually doing. The thing I don't like about treatment planning books is that they are very generic and they conflate the goal with the objective, the problem with the goal and objective. And so they go on forever and nobody wants to read them. And when I say that they are generic, insurance companies do not like these generic plans. And here's how they're generic. You click on a diagnosis and up pops a whole bunch of goals, not even problems, goals. And you then click on the goals and you click on the goals you want and up pops a bunch of objectives. And then you click on the objectives you want and up pops a bunch of interventions. It's boilerplate, and insurance companies don't like boilerplate. They want you to be thinking about what you're doing. And when you do, then your treatment plan is actually written for your client. It's not generic, and it's actually helps you formulate your treatment for your client. So in other words, if any of you have heard the word psychobabble, you don't have to use it. You don't have to use, you can speak English or whatever your language is that you're documenting in. You know, some people do therapy in Spanish. You know, if you're in a clinic where you can document in Spanish, document. Well, actually, that's probably not true. You probably do need to document in English, but it makes it harder if you're doing therapy in Spanish to document it in another language. All right. So that is the treatment plan. At the lunch break, I will go through and I will answer as many questions in the Q&A as I possibly can. What I want to do now is just have you stand up and do a really good stretch. And we're going to go on to writing session notes. Here's how I want you to feel about writing your session notes. All right. So we're changing gears. So take a good stretch. I have to do it myself. Here's the definition of a session note. They are notes documenting or assessing the contents of a conversation during a private counseling session or a group, joint, or family counseling session. They must clearly relate to the mental health objectives and goals of the client. They are a standalone document regarding medical necessity. They identify progress, and they have a clear link to the treatment plan. And they are the part of the medical record. They are the biggest part of the medical record. Here is all the identifying information that you need. You need the name and date of birth of the client on each page of the record. You ought to have a client number if you're not in private practice. You don't need one if you're in private practice. You need the date of the session, and you need the date of the next session. The date of the next session indicates continuity of care, and it also indicates not only continuity of care, but if you don't have the date of the next session documented and the client does not show up, you cannot bill that client for that missed session. So it protects you and in multiple ways. You need the time of the session, not just the start time. You need the start and the stop time. This is a really big deal. The start and the stop time is how the insurance company verifies that you're doing either a 90834 or a 90837 because the length of time for those sessions are different. So you can't just say individual 45-minute session 90834, because first of all, a 90834 can be 36 to 53 minutes. So the start and stop time. You need the location of the session. And the location can be office, it could be, which is 11. You can also use O2, depending when you're doing video. It depends on what your insurance company wants. You need the type of session. In other words, is it individual? Is it family? Are you doing a group? Of course, you need the diagnosis with the code and the name. You need who's present. So if you're doing family, you have to indicate who's present. Even when I'm just doing individual, I indicate who's present. You need the medications with the dosage and frequency. You need the symptoms. And when I put the behavioral examples of the symptoms. Now you can put either the symptoms or the goals on your session note. I like to put the symptoms. That's because I want to know what, not symptoms, the behavioral examples. I just copy and paste them from my treatment plan. I want to know what they are so I can refer to them. You need the ICD-10 code on your note. In terms of clinical content, you need subjective findings. In other words, what does the client say to you about themselves? You need the objective findings. This is not what the client does. This is how the client appears objectively to the therapist. I'm going to talk about these in much more detail, so don't freak out on me here. Just stay grounded with your feet on the floor. You need the clinical interventions. You need an assessment. Part of the assessment is a risk assessment. It's also progress and client's response. And you need plan and prognosis and homework. You also need something I call the verification. If you're doing telehealth, you need to verify that you need a whole bunch of things to verify your telehealth, what you're doing, telehealth confirmations. You need the medical necessity. And well, actually, the truth is you don't have to say continued treatment is medically necessary to address, maintain, stabilize, improve. I put it on my session note, on each of my session notes, because I don't want any questions. I treat it as, make it as clear as humanly possible. And you need your signature with the licensure by your signature and the date that you signed it. If you are using a practice management system and you lock your notes, it will automatically date it on the day that you lock your notes. If you're storing your notes in your computer like I do, then you print them out and you sign it the day you print it, and you have a note that goes with your you have like a very short letter that says these notes were signed the date they were printed out, but they were created on X date. Okay. What are telehealth confirmations? We're going to get there. I've got to answer Jason's question. The start and stop time on the EHR calendar doesn't count, correct? Like I book each session for an hour and that doesn't give actual start and stop time. Booking for an hour does not give actual start and stop time. Many EHRs do not give, I don't even call them EHRs, they're online platforms because they're not EHRs, which I will cover later. Many practice management systems do not give start and stop time. You need to do that. You need to manually write that in your note. Um, I am going to get to the last question about clarifying the difference between what's to protect confidentiality. That's what this is, a lot of what this is about. Okay, subjective, or the client's, is from the client's perspective. So what is the client coming in to talk about that day? And I use a quote. I was trained to use a quote largely because insurance companies want to hear in the client's own words what they're dealing with that day when they're coming into session. So what does the client want to discuss? All right. Another reason I use the quote is because when I use a quote, I capture the emotional content and the what's happening in what the client says. Otherwise, I'm giving a big, long narrative about client reported this and that and that and that. It's too much. That's part of how you violate confidentiality. You use a quote that captures the essence of the session. So here's a quote that I used for this client. I got hit by a wave of dread. It hasn't gone away. I can't pay my rent. I hate myself when I feel this way. I only feel better when I talk to my sister. All right. I tend to overquote. These ellipses, those 3 dots, means he said these things at different times during the session. I could have just said, I got hit by a wave of dread. It hasn't gone away. And I could have explained everything else in the note, like under my assessment, client's depression is exacerbated by financial worries and inability to pay his rent. But I just decided, because I tend to overquote, I can't pay my rent. But I don't need to. I hate myself when I feel this way. That could also go in the assessment. This wave of dread is making him feel worse about himself. I only feel better when I talk to my sister. That points to the isolation that this client is experiencing. But do you see by these sentences, these short phrases, that you're capturing the content of the session? So you also need a risk assessment. This is the same risk assessment that you have on your treatment plan. In every session note, a risk assessment. And always, as part of your risk assessment, diagnose whether the client is having a sleep problem. Document sleep problems, because sleep problems are very serious. When you have a really serious sleep problem, you can be delusional, you can fall asleep at work, so you can't actually do your work, you risk getting fired, you can fall asleep at the wheel, risk killing someone, including yourself. And make sure that you address it. Now, you might not address it in every single session. In fact, I'm sure you won't be addressing it in every single session, but it needs to be documented. All right, so I wanted to make sure that we had what the client said, right, the quote, and your assessment of what's part of what's going on. And here's more assessment. This is the objective, or what the therapist observes. This is how the client appears to the therapist, visually, cognitively, behaviorally. So here's a whole bunch of options. On my notes, I think I have over 30 some options. Make sure you check engaged, okay? Engaged and motivated. Because remember at the beginning of the workshop, I said, I didn't say, one of the criteria for medical necessity was that the client had to be engaged and motivated. So make sure they're engaged and motivated. Now, what are the interventions you're going to use? You want to list your interventions. And like I said earlier, some therapists, particularly at the beginning, don't really know what interventions they're using. They're just doing therapy, and they don't know that something they're saying actually is really and truly a legitimate intervention. And that's okay, because we were all there, right? Just use insight-oriented, because change doesn't happen without insight. Insight doesn't guarantee change, but change doesn't happen without insight. So if you're not sure, put insight-oriented. And there are other therapists who've been around. So most of you on this in the training today have been around for 20 years or more, and you've taken so many trainings, so many in-depth trainings that you're not even sure which one you're drawing from. Well, you know what? You can say insight-oriented, you can say internal family systems and CBT, because you might be doing all of those. Okay. Listing the modalities is not enough. You need to have a description. What specifically are you doing using those modalities? So here are some different descriptions I have. Help client identify triggers or burdens, strategize solutions, reframe cognitive distortions, develop compassion for self, unblend with or externalize anger, teach client coping techniques, mindfulness techniques, communication skills, meditation, provide psychoed, safe space, an invitation to, hope for the future, emotionally corrective experience. These things in white, these are prompts. These are your intervention prompts. These are things that you want to keep in mind. Are you helping a client do something? Are you teaching a client something? Are you providing the client with something? Are you engaging the client in something else? You know what your interventions are and how you do them. Some of these are written with very treatment-specific language. Unblend with is an internal family systems language. Develop compassion for self is internal family. Reframe cognitive distortion is CBT. Strategize solutions is CBT. Identify triggers is just about any therapeutic modality. Identifying burdens is IFS. You can tell I do a lot of IFS. Teaching any of these skills is cognitive behavioral. And you can provide psychoed no matter what therapeutic modality you use. You can create safe space using AEDP, IFS, CBT, narrative therapy. I mean, I actually created a list of, I think, 16 prompts and well over 100 interventions. And then I periodically add to it. But in the creating of them, I got them in my own head. So I can look at my paper, or I can just now I just kind of write them. And I actually went back looking over some of my old documentation the other day, and I went, oh, this is pretty good. Oh, I'm doing what I'm teaching. All right. All right, now here's some descriptions. Here is supportive therapy. Provide active listening, mirroring, and validation. Teach sleep hygiene and social skills. Identify supports and recommend a caseworker. So provide active listening, mirroring, and validation. That happens in just about every therapeutic modality that you could use, but supportive is one of the main ones. What's really supportive is teaching sleep hygiene and social skills and identifying supports and recommending a caseworker, which is what I did with this client. CBT, help client identify trigger to depressive episode, identify challenge and reframe cognitive distortion. Internal family systems, engage client in reflecting on patterns. I like to use this a lot, by the way. Engage client in reflecting. It's okay for a client to reflect on something or reflect on and process patterns of personality, how anger at himself and losing focus impacts feeling connected to self and others. In fact, I would just say engage client in reflecting on patterns of personality. And this would be the assessment. Anger at himself and losing focus impacts client feeling connected to self and others. That's really an assessment. But very often, clinicians write assessments in their intervention. Here is another intervention. Help client feel compassion towards self. Witness and unburden legacy burdens. Mindfulness. Engage client in guided imagery to help develop feelings of safety and belonging, or teach client guided imagery technique and to help develop feelings of safety and belonging. You would write it a different way. This is how I wrote it. Okay. How many interventions do I need, and how do I know which ones to document? All right. How many interventions you need? There's a standard formula that can be broken. The standard formula is about one intervention for every 15 to 20 minutes, so 3 or 4 interventions. But are you always going to have 3 or 4 interventions? No, you're not going to always have 3 or 4 interventions. What if you're doing EMDR and you have one intervention? You're targeting one specific issue with EMDR, and you're being specific about how you're using the EMDR, and that takes the whole session. This is your session. And when I say your, I mean yours and the client's session. So standard 3 to 4, but really it could be 1, it could be 2. It just depends. Now, how do I know which ones to document? You document the ones that have real clinical impact. When we were going to offices, and we were walking with the client to the office, maybe down the hall, getting them from the waiting room and walking them into our office. As an intervention, we might let the client lead the way to the office and walk in first. That's, for some clients, that's a really important intervention to give them a sense of agency. But are you going to document that? Probably not. All right. So you document the ones that have real significance in your session. And how do you determine that? Well, that's kind of the art. All right. Now we have to assess our session. We're doing good here. So the definition of an assessment: the action or an instance of making a judgment about something, the act of assessing something. An assessment helps. So this is Merriam-Webster's dictionary definition. Here's how it works in mental health. An assessment helps to make sense of and justifies your intervention and the diagnosis. It relates to the quote, and it helps to explain how the client responds to the session. Now, that's a lot, but it's possible. And I'll give you some examples. And you're going to get to practice it in a while. All right. So based on what you know about the client that's described in the diagnostic summary, recorded in the treatment plan, and in the current session, what is your understanding of what happened in the session? You can also include how the client responded to the intervention, which is different than progress. It's a different kind of response, because a client could have appeared very anxious, but the final outcome of the session was quite positive. Now, here's a kind of a formula for how to think about the assessment. Okay, this is called the so what question. I did not develop this, by the way. This was developed, or at least taught to me, by Elizabeth Arias, who has a wonderful broadcast called, I think it's called Purely Clinical. Oh, now I can't remember what it's called. Purely Clinical, something like that. I'm actually going to be interviewed by her in September, and I don't know when it'll be aired, but I'm doing the interview in September. And Elizabeth knows a lot about documentation, and she's also a really good clinician. So here is what I learned from her. The so what question. I got hit by a wave of dread. So what? Well, if you answer so what, the dread reinforces the depression, which is the diagnosis, right? It hasn't gone away. So what? There's an increase in hopelessness and a deeper depression. I hate myself when I feel this way, and I only feel better when I talk to my sister. So what? I mean, don't we sometimes want to ask the client, so what? Right? Well, this way we get to do it in a clinical way rather than a judgmental way. So hating himself increases his alone, and he only feels better when he talks to his sisters, is indicating an increase in aloneness, and depression is turned inward as anger. So what? He could lose his apartment. He can't pay his rent. He could lose his apartment. So just always ask your question. Why does this matter? So what? What's the big deal about this? So here are some possible assessments. Client's sense of aloneness seems to be reinforced by financial stress and fears. He may lose focus as a protection from feeling alone and hopeless. Now, I say he loses focus. He loses focus because, remember, I had all those ellipses, and he said those things at different times. He was just pinging around that session, like, and this and that and that and that. And how many of us have clients who are not focused, and, you know, as soon as they start working on one thing and get a little ways into it, they skip to the next thing. Well, my understanding of that is he may lose focus as a protection from feeling alone and hopeless, or as a defense from feeling alone and hopeless. Here's another one. Client's anger at himself impacts his ability to focus, which impacts feeling connected to self and others. Or client's anger at himself seems to impact, or it could be that client's anger at himself impacts ability to focus. It's possible that client reports feeling better because he has a plan of action. Because at the end, he reported feeling better. And then, of course, progress would be client has a plan of action and feels better. But the assessment is it's possible that client reports feeling better because he has a plan of action. Okay. Are we asking ourselves or the client? So, oh, nice question, Rebecca. Are we asking ourselves or the client? So what? You're asking yourself, so what? But you can ask your client in a different way. How does that impact you? What impact does that have on you? How does it affect you? Those are like narrative questions, right? All right. There's additional assessments needed. The response to the treatment plan. This is kind of like prognosis, but not quite. Is treatment moving ahead at a 3, kind of normally, as expected? Nothing great, nothing terrible. I generally put a 3, unless the client has one of those sessions where I once, about 2 years ago, I had a client said, that was a boom moment. And I said, well, what do you mean by a boom moment? She says, it's just everything fell into place. I get it. Like, okay, cool. Well, I rated that response to treatment as 5 that day. Because, like I said before, we don't have many chances to celebrate. Let's celebrate. And also it shows in your session notes or your progress notes what's actually, that there is a good response. All right. Is the client oriented by person, place, time, and event? Now, up until recently, event was not part of the picture, but event got put into the picture. So it's oriented times 4, not times 3. Is the client, how do the meds appear effective? So a lot of therapists really bulk at documenting whether the meds appear effective or not, saying that's out of my scope of practice. Prescribing meds is out of our scope of practice. Finding out whether there are side effects is not out of our scope of practice. Finding out if they are taking them regularly is not out of our scope of practice. We are the first line of defense. We see the client every week or every other week. The prescriber sees them every 3 months or less. So we need to keep track of this. I have a client who up until the past, I've been seeing her for 9 years, or God, goodness, maybe 10. Now we just went to monthly because she's very stable, but she doesn't want to lose the connection. But before, when we were seeing each other weekly for about, she started showing up and her hair wasn't washed. And, her hair was kind of stringy and greasy. And her mood was really, wasn't flat. She was presenting with hopelessness. And it took me about 3 weeks. And I went, are you on your meds? No. How long have you been off of them? About 3 weeks. How come? I don't have time to get them. Well, in truth, no, I don't. I have to see my psychiatrist in order to get my meds, and I don't have time to see my psychiatrist. Well, this has now become a clinical issue because it's self-care. And, you know, she has very real constraints. She is a full-time, fully employed, full-time with 3 kids and a husband who at the time was not very involved in child rearing and child care. And so we had to figure out how she could get her meds immediately and how she could arrange to get an appointment with a psychiatrist. And so that became the focus of our session, or at least part of the focus of our session, as well as thinking that she, you know, is last on the list for people to take care of. So I'm proud to say that this has not happened since, but it happened several times in our work together before then. Also, you might have an elderly client or a child who all of a sudden is demonstrating cognitive functioning issues. And one of the first places you want to go to are the meds. Are you taking your meds? Maybe they're doubling up on their meds. Maybe they're having, you know, because they're confused. Maybe the meds are the reason they're confused. And then you recommend a med eval with their prescriber. Anything that's not normal or within normal range needs to be explained. Okay, now we're going to go on to progress. I see a lot of questions, which I will either answer by writing during the lunch break, or I will answer after the lunch break. All right, progress. I love this part. One of my favorite parts. You must be specific in behavioral in progress. It's not good enough to say no progress, moderate progress, excellent progress. Progress is insufficient. That's all insufficient because, like with the rest of your documentation, it's not behavioral. So here are some examples. Client was or was not able to. Client gained clarity or insight. Client gained compassion for self or others or for his struggle or for their struggle. Client continues to struggle with. Client reported feeling grounded, relieved, reassured, unburdened. You might not have all of these in one, but I'm giving you multiple options. Client identified next steps, her emotions, her truth. Named family roles and their dynamics. Set healthy boundaries. Reported anxiety reduction from 8 out of 10 to 2 out of 10. Showed an interest in. Progress takes many, many, many forms. And one of the ways I document progress is I ask the clients, so what are you taking away from our work together today? And they'll tell me, or they'll say, well, gee, I'm not really sure. And then, of course, my heart sinks because I think, oh, did I do a good enough job? But after we talk a little bit about it, we find out that they actually learned something. All right. So here's examples of progress for a session I had with this client. Client was able to experience safe space, allowing him to identify and tolerate some feelings without using distraction as protection most of the time. Now, I added significant progress because that was a lot of work. That took weeks and weeks and weeks of work for this progress to show up. But I don't have to write significant progress. That was my way of celebrating. This was enough. Or client gained compassion for his struggle to identify his feelings, though continues to struggle with appropriate ways to express them. Moderate progress. I want you to identify even the slightest progress. Let me go back one. Again, you identify progress by using words like was able to, was not able to, gain, lost, regressed, improved, struggled with, showed interest in, demonstrated, completed. These are your progress words. You will be able to identify progress when you start thinking this way, or you'll ask your client, so did you make any progress today? You do it in your way. All right. Identify even the slightest progress. A lot of therapists think that they need to keep putting no progress in order for the insurance company to keep authorizing additional sessions. If you keep having no progress, a reviewer will say, well, clearly the client has reached their highest level of functioning and they don't need weekly sessions. And what are you doing with them anyway? And you know perfectly well that if the client doesn't have weekly sessions, that the client is going to decompensate. So you have to identify even the littlest, tiniest, slightest bit of progress. I want to give you an example. First, I'm going to take another drink of water. This is not one of my clients. This is the client of someone who did a training with me many years ago. And it was such a great example that I use it to demonstrate documenting very slight progress. She was working with a 14-year-old girl, came into her office, walked in, sat down, and there was a table where she was sitting. And the client went like this, sat, put her head down on the desk, and went to sleep for 45 minutes. And the therapist stayed there with her for 45 minutes and did not fall asleep, which is something that I might have done because I thrive on engagement. And that was, like the first 3 sessions. How do you document progress? How do you document progress like that? What is the progress? This is going on for 3 to 4 sessions. The client comes in, sits down, puts her head on the desk. Yes, Rebecca, the issue is about developing trust. That's your assessment. Client is developing trust or is in the process of developing trust, safety and comfort. Yes, this is your conceptualization of but what is the progress? Client keeps returning for her sessions. Okay, so this goes on for 3 to 4 sessions. Now the client comes in and she says, hi, sits down and puts her head on the desk and stays asleep for another 45 minutes. What's the progress? You can do this. Yes, client said hi. Increased in social engagement. Yes. Increased socialization and communication. She speaks. Yes. She greeted therapist. Exactly. Talking. Engaged with therapist. Engaged briefly with therapist. Yeah. 100% increase in verbal output. If you want to get measurable. Okay, that's the progress. Okay, now, another few weeks goes along and she comes in and she says, hi, Yeah, I'm okay. Then she sits down and she puts her head on the desk. So there's more increase in socialization or in engagement. She continues to come back. And now you have to have an assessment. The assessment is that this is a trauma case. This may be the only time the client is safe enough to sleep. It could be that the client feels safe enough to let down her guard to sleep, and that it will take time to develop enough trust that the client feels able to disclose. So that would be your assessment. Do you see how this is about real people, real clients, and not about a diagnosis? Could sleeping be a sign of ambivalence or avoidance? It could be. And in fact, if there's no trust, wouldn't there be? It could definitely be about avoidance and ambivalence. Then that's part of your assessment. All right. But the progress, she keeps coming back. She doesn't, if you're seeing the client in school, she's not skipping school to avoid you, right? All right. Plan and homework. Insurance companies like to know that the client is engaged in therapy between sessions. And you know what? We do too. So homework can be as simple as keep a sleep log, and it can be as open-ended as observe insights gained in therapy, or observe and document behaviors identified in therapy. Continue to reflect on insights gained. Homework does not have to be always concrete. It doesn't always have to be written down. Sometimes I have clients, I say, how would you feel about drawing your experience of this and show me next session? So the homework, draw your experience of X, Y, and Z and show in next session. Of course, if you say show in next session, then you have to, on the next session, you have to say reviewed drawing, or client did not bring drawing, or something like that. All right. You also need to know what the plan is, and the plan is, are they going to continue with current treatment? In other words, are they going to continue seeing you weekly or every other week or bi-weekly? Or are they going to plan for discharge? Or are they going to, I don't know, I can't think of another one off the top of my head. Are you going to make referrals to somebody or someplace? Are you going to make a psychiatric referral or a referral for psych testing? Or are you going to recommend a group or a day program or inpatient hospitalization or other? I work with a lot of people who struggle with emotional eating, and I have a couple of nutritionists and dietitians that I refer to. So I would refer to a nutritionist, and then I will put the name of the nutritionist I refer to. So that is your session note. Remember, we had the diagnosis and all the supporting evidence, and now we have medical necessity. Continued treatment is medically necessary to do all of those things, and we have justified your treatment. Because the next thing we're going to do is write a practice session note based on that interview. Jennifer, you said it looks like my questions from before and during the break are gone since I returned from lunch. Okay, it looks like Drew is answering your questions or your concerns. I answered all the questions except a few. I typed out my answers before I even took a lunch break. So I don't know why they would be gone. I typed answer and I hit send. So if you don't get your answers, keep asking. Do you record progress between sessions along with session assessment, noting progress regarding session? Yeah, I note whatever progress has been reported or demonstrated. So Elizabeth, I hope you got that answer. Okay. You are welcome. Any more questions? Hannah, you write a very interesting comment in the Q&A. I have been audited 2 times by Maryland Medicaid. Mostly Medicaid is looking to see if there is a note for each of the billed sessions or they want their money back. Yeah, this goes along with something that I talk about in the section called red flags. Don't bill a session until you write a note. All right. Will you share your email address and website with us? Yes, I will. It is, I've written it in the answers. I will write it in the chat right here. And it is also in the manual. Okay. My email address is and that is also in the manual. And if you give me your email addresses at the end, I will make sure you get everything that you need. How do you document the need for 90837 and 34? I will address that later. And you can also, I also wrote a blog about it. No problem, Rebecca. Okay, it looks like there are no other questions. What I want you to do now is go to the back of your manual and take out your practice session note. Here. I'm looking for the blank one. I pulled out the one that has all my, here we go. Here's the blank one. Okay. It says session note practice. Take that out and write a session note for that first introductory session. Diagnostic session, write your session note. And we'll take like 5 minutes. Okay, let's review the session note. So, what would you use as a quote? You want to write it in the chat. I can't sleep. What else? I don't know how to do my documentation and I worry I'm going to lose my job. I'm not sleeping. I worry all the time. Great. I'm worried about losing my job. I procrastinate and then I have to work several hours on Sunday. I want to master my documentation. I feel like a bad person. I want to do my paperwork with ease. I worry so much I have trouble going to sleep and wake up thinking about it. I worry I will lose my job. Good. These are all perfectly reasonable quotes. One of the things you want to do in an adjustment disorder is point to what the person is dealing with, the circumstance or the situation. Yeah, I'm worried about losing my job. Okay, great. I procrastinate and then I have to work several, I want to master documentation. I think, yeah, okay. Perfect. All right. So how does the client appear? Let's put it in the chat. Jennifer, nice answer. Nice quote. Objective. How does the client appear? Calm, sad, engaged. Calm, engaged, yet anxious. Appears defeated. Defeated. Appears anxious, yet engaged. Oh, they're coming in so quickly now. I'm having trouble keeping track. Anxious, engaged, and tired. Yeah. Melancholy. Anxious, worried, stressed, frustrated. Great. Stressful, anxious, guarded, engaged, and motivated. Guarded. That's an interesting one. Distressed, but that's how she appears to you. Distressed, appears anxious, and reports feeling hopeless. Defeated. Wow, defeated came up a number of times. Interesting. I haven't had that one yet. That's really interesting. That might be how I'm feeling during the pandemic. I don't, keep on doing this. All right. Okay, so good. Just make sure you include the word engaged. That's the operative word here, engaged. Right? She needs to be engaged and she needs to be motivated. So, here's what I put for my quote. I go to bed thinking about it. I wake up thinking about it. I'm afraid of losing my job. You all kind of put the same thing. And what I checked off under my objectives was anxious, engaged, and hopeless. And yeah, I can see how people would see her as sad. And I would also see how people would see her as calm because outwardly she presents very still, but inside she's racing. Great. Client appears distressed, appears anxious, and reports feeling hopeless. Yes. This is an area you can actually use checkboxes for or drop-down menus for. Somebody asked earlier, is it okay to use checkboxes on your treatment plans and your session notes? The answer is yes. That's not all you can use. You have to have a narrative that describes certain aspects of it. But when you're talking about how the client appears, you can use checkboxes and drop-down menus. You don't have to say reports feelings of hopelessness. Although I think what you're doing, Elizabeth, is distinguishing between how she appears and what she reports. It could be to you that she doesn't appear hopeless, but that she reports being hopeless. So I'm just trying to, think through in your thoughts. Yeah. Defeated, me too. I hope you don't stay defeated about this. Please don't. Okay, yeah, great. Okay, good. Good. This is what I do when I review people's notes. It's like editing papers. You got to get into the head of the writer. All right. What is her response to treatment? What would you say? Just put it again, put it in the chat. Five, four. Okay. You're actually going to justify. Yeah, very good. She has a willingness and motivation. That's right, Jeffrey. That's right. You're actually going to justify why you put a 5 or a 4 in your assessment. Yeah. Okay. Yeah, because she has greatly increased hopefulness, which actually goes towards progress. And right, response to treatment plan is a 5. You can put in your assessment. Client's response to treatment is a 5 due to her increase in hopefulness or decrease in hopelessness. And then in your progress, you would say, client went from hopelessness to hopeful by end of session. But, well, not but, and is she oriented? She's oriented times what? Yes, times 4. Do the meds appear effective? NA, that is correct. Well, we actually don't know if she's on meds or not. For the purposes of this interview, she's not on meds. There was no opportunity to find out if she was or she wasn't. So yeah, the question is she taking meds? At this point, if this was the full interview and you didn't get around to the question about meds, you would put unknown at this time. But if you did get around to asking that question, or it was written on the intake form, the diagnostic summary, then you would either put NA, meaning she's not taking meds, or you would rate it 1 to 5. Now, what's your narrative for the assessment? How do you make sense of this? She comes in and she says, I'm afraid of losing my job. I go to bed thinking about it. I wake up thinking about it. Patrick, the answer to your question is yes. I go to bed thinking about it. I wake up thinking about it. She's oriented ×4. She's not on meds. Patient seems motivated to accept help and willing to explore interventions. Could write client did not, oh, okay. Why is the client coming for help? In your first session note, you probably want to give a reason why client is seeking help. Yep, it could be a quote. Yes, the narrative goes back to why they're here. Everything needs to connect. So I'm kind of waiting on some answers here. Are you thinking? Do you need me to give you my answer? Client reported difficulty sleeping, inability to perform duties and responsibilities, concerned about losing her job. Client seemed guarded about asking for help from supervisors or peers. Client's response to treatment plan is positive. Client presented as hopeful at the end of session. That's an incredible assessment. You have combined areas that I separate out. You've done it according to many session note templates. You've just done a great job. I separate all of those out. I separate out progress from assessment. Even though progress is part of assessment, the reason I do it is when you have a box, here, I'll put it over here. You have a box that says something like clinical content. And clinical content is very open-ended. And what happens when you have this big empty box for clinical content is you start writing a lot of story. So on my note, I separate it all out. Because clinical content is what the client says, in other words, what the client wants to work on, what the intervention is, and what your assessment is, and what the progress is, and what the prognosis is. So and it's very easy to miss one of those. So on my note, everything is separated out. Now, you may not have that option in your plan, in your template, but you can use this template not as your final treatment plan, but to help inform what to write and how to separate out all those areas. Now, let me just read this comment here. Therapist gathered necessary information to understand the presenting problem, then explored cognitions and feelings associated with problem, then helped client identify a solution to presenting problems. Lastly, we made a plan to implement a solution. Dolores, that's brilliant, but it's an intervention, not an assessment. Fabulous intervention. brilliant at what's the word? Articulating clearly what the therapist did. Yeah, I'm hearing I'm hearing that people want to see it. If you put your email in the chat at the end, you will get a copy of this. Probably not tonight, probably tomorrow. So here is what I wrote for my narrative. It appears client's anxiety is focused on her job performance and fear of losing her job. She reports not understanding expectations, not receiving training, and not knowing who to trust. This has led her to seek help. Okay. Do you understand? Do you see how I have linked the subjective, what the client says, with how the client appears, with and created this narrative, this assessment narrative? It appears client's anxiety is focused on her job performance and fear of losing her job. She reports not understanding the expectations, not receiving training, and not knowing who to trust for help. This has led her to seek help. That is my understanding of what's happening in the session. Yes, this is how we are conceptualizing the case and the session. Good. You're seeing how you link the narrative to the presenting problem. I'm looking at the chat right now, so bear with me because I really want to respond to this. How is the narrative different from the subjective? Because you're tying together how the client appears with what the client says. Yes, the client can have multiple diagnoses. Somebody is taking from the Q&A answers that I wrote. Okay. I wrote a whole bunch of answers during the lunch break in the Q&A, and people are posting them. Then how many objectives under the goal? Oh my goodness. People are always asking how many goals, how many problems, how many goals, how many objectives, how many interventions. You need to have at least 2 problems. If you don't have 2 problems, the insurance company could say this person isn't distressed enough to warrant being in therapy. It's ridiculous, but that's what they say. But it's really easy to find more than 1 problem, because a diagnosis has, X number of symptoms associated with it. So you can make a symptom a problem per symptom, or you can lump the symptoms together for a problem. Objectives for a session note. Well, objectives is how the client appears in a session note. Objective. So you can have many, you can have quite a few. I'm really sorry the Q&A disappeared when you left for lunch. Ask your questions and I'll do my best to answer. But what I'm seeing on the chat are a lot of answers to my questions. And I guess Drew is doing that for us. And I really appreciate it. Thank you, Drew. Had I known that would have happened, I just would have saved it. I apologize. Is it making sense, this narrative? Okay, good. Excellent. Thank you for asking. Notice that I use client, it appears that. You can also say it's possible that. I like to use it, client appears to, or it appears that client. I like to use the word appears. Otherwise, if you simply say client's anxiety is focused on her job performance, what you're doing is creating a cause and effect relationship that you can't necessarily prove unless the client states. Then you would say, client states that or reports that her anxiety is caused by her job, issues at her job. Oh. Okay. Risk. Is this client at risk for anything? What's the client at risk for? Job loss. That's right. Yes. Now, she's not at risk for suicide, homicide, assault, or violence, but or assault, but she is at risk for job loss. Interventions. Suicide by paperwork. Sometimes it feels like that. Kill me now, right? Okay. All right. So what you may not remember is the modality that Liz used is solution-focused therapy. So what did she do using solution-focused therapy? In the narrative or description part of the intervention, say what she did. She gave homework to find support. What else did she do? Explored with client how she might reach out for help. She focused on possible solutions that the client generated, asked the client when she had had experience in a similar issue before and how she resolved it. Helped identify finding someone to trust and talk to with help, or suggested. Yes, she asked, how have you approached this? And help client problem solve, strategies to help her advocate for self with coworkers. Yes. She co-created a treatment plan with the client, right? Here's what I wrote. Engaged client in identifying the problem, identifying strengths, past successes that support her in future success, rated level of anxiety, and identified one step to reduce anxiety by 1 point, co-created treatment plan. Yeah, great, Jessica. Therapist asked questions to understand client's current symptoms and what coping skills she had used in the past. Yes, great. Okay. Now, if this were a full session and you were, and this was your diagnostic session, you would also include, reviewed paperwork, agreements, signed documents, signed all documents, reviewed HIPAA, office policies, informed consent, social media policy, and took a brief history of presenting problem. So those are the things you want to make sure you do in your first session, that it's documented. Okay. What modalities? Oh, excuse me. Modality rationale. Yeah, you do want to include a modality rationale, alleviate emotional. This is kind of like medical necessity. And I'm sorry, I didn't have that in the first part because I just added it. Ugh. All right. You want to alleviate emotional disturbance, reverse or change maladaptive behaviors, facilitate coping mechanisms, encourage personal growth and development. Thank you for your request, Rebecca. Yes, would everyone please make sure they are responding to everyone? That way everybody can see it. Because all of your comments, at least they all seem to be relevant to everyone. Plan and homework. Okay, what's the plan? Continue with current treatment plan or weekly sessions. And did she make a referral? Not really, not at this point. But what's the homework? I'll tell you what I put as the homework. Start to notice who might be trustworthy and knowledgeable to ask for help. Return next week. Good. Progress. Now, in this section, you can either put NA, no progress, because it's the first session, or you can actually document progress. That is, client went from hopeless to hopeful. Client was able to co-create a treatment plan and commit to taking next step. I mean, that is progress in the first session. So you can go either way. I like to document progress all the time. Prognosis. Based on the diagnostic summary, access to resources, motivation, and demonstrated ability to engage, client's prognosis is 5. Yes, I'm reading what's in the chat and they all look great. And medical necessity. So what do we want to do with medical necessity? The same as the treatment plan. Address and reduce symptoms and improve functioning. All right, that is your session note. Notice there's no story. Very, very, very little story. Just enough information to get the sense of what's going on. This is what maintains confidentiality and privacy. You capture the essence of the session. You reduce the time you spend writing. You reduce the amount of time you spend. You reduce the amount of time you spend writing. You save the story for your memory notes. Now, saving the story for your memory notes. In other words, if the client says something specific that you want to remember from session to session, that's what goes in your memory notes or the psychotherapy note. It does not go in the progress note or the medical record. That is, the progress note or medical record is what you have been learning. You save the story for your memory notes. The kind of therapy I do with people, I often need to go back to the previous week's notes. I write verbatim certain things that they say in order to go back and remind us of where we were. So if that's what you have to do, particularly because my memory will not do it for me anymore, then you do that, but that belongs in the memory or the psychotherapy notes. Now, this is true except under certain circumstances. If there's risk, you write more than less. You have to write how you identified it, what the level of risk is, how you're going to address it, why you addressed it, why you think that the client is or is not at risk or at the level of risk the client is at. If the client gives you a gift, I don't know, have you ever had a client give you a gift at the holidays? I have a client who gives me a gift every single holiday, and I've been seeing her for a long time, except during the pandemic. So, some therapists just have a blanket policy. They don't accept gifts. That's fine if that's your policy. It actually makes it kind of easy, but the client might give you a gift anyway. And then you would have to say, I don't accept gifts. And then you're going to have to document how the client responded to saying, I don't accept gifts. Or if you do accept a gift, you want to respond to how the client, what you said, what you did, how the client responded. If the client wants a hug, you may have a policy of no touch. That's great, but the client may ask anyway. And if you do have a policy of no touch and no gifts, it ought to be in your informed consent. But if the client wants a hug and asks for a hug, and you feel you know the client well enough and trust the client well enough to do that, then you do that, because it can be incredibly comforting and a wonderful intervention, but only if you trust the client and the client trusts you. And then you document it, because frankly, you don't know if and when a client is going to turn on you. Okay. I have had a case where a client turned on me. It was really, really, really unpleasant. And I'm not going to give you the specifics, but I managed to by getting a consultation with an attorney to figure out how to deal with it. And I dealt with it just fine, and there was no board complaint. I can give you another example of the time. This didn't happen to me. This was somebody else who was working with a 71-year-old woman on Medicare with multiple medical issues, which sometimes made it difficult for her to get to the office. And so periodically, even though Medicare didn't allow it, they would do video sessions. Otherwise, the client would have missed a ton of sessions. So this was to accommodate the client. And over time, it became clear that the client was being subjected to elder abuse by the family who was living with her, and that the client was incapable of dealing with it. And it went on for months and months. And the therapist said to the client, we've got to figure out a way for you to deal with this, or it needs to be reported for elder abuse. And the client said, okay, well, I'll deal with it. Well, more months went on, and finally the therapist said, I need to report. And a grandchild was living with the client, and the client says, don't report. And if you report, I'm going to report you to the board. And I'm going to tell them that you were doing video sessions. And of course, the therapist tells me, now what she asks is, now what do I do? Right. So, it wound up working out okay for this therapist. She figured out what to do. And in fact, she told the client that they were no longer going to be working together. It was clear that the client was stating that, and she wrote this in her note, that the client said that she was not at risk and not worried about risk, and why the client was not worried about risk, documented it in a discharge summary, and documented it in a termination letter. But this was with a client the therapist said loved her. So she was shocked. So you don't know. Okay. So in this case, if it didn't, If it isn't documented, it didn't happen. So in the case of these special circumstances, if it isn't documented, it didn't happen. This is how I want you to feel when you are done for the day, when you have finished, or for the week, when you have finished your clinical week and all your notes are done. This is what I hope for you. Now, let's go to the case and collateral contact. Question here, when do you write your note? I kind of covered this at the beginning. Best to write your note right after the session. If you can't write your note right after the session, write it at the end of the day. If you can't write it at the end of the day, please do your best to write it within 3 days. This is the part that I didn't say. After 3 days, your memory can be called into question. So if you have to testify and your date stamp on your note is a week or 2 or 3 weeks after your note is written, the attorney can call your memory into question. It is not personal. That's their job, but it will feel personal. So please do your best to get them done. All right. Case and collateral contact notes. It's really important to write a case and collateral contact note. I'm a member of a supervision or of a consultation group. I take my note with me, or now I sit at my computer, and I write on my form the information that's needed from that I got from the consultation. These can protect you in legal issues or board complaints that you've gotten consultation and that you have spoken with other people connected to the case. Because we all do it, right? We all get consultation and we all connect with other people in the case. We all connect with people in the client's life. When it's needed, we have to document it. So here's what's needed. The name, and again, if it's an agency, the client number, the date of birth, again, on each record, or each page, the date of service, the time of service, the diagnosis, the type of consult, the symptoms, the reason for the consult, the parties involved, the agency or relationship to the client, the clinical justification, the follow-up needed or recommended, the why the consult was medically necessary, and signature with licensure and date. Those are all the things that are needed. All right, a case consultation. Now, this information, I will tell you, was gathered before the pandemic, and I think some of it is changing because we don't have the opportunity to do in person the way we used to. So a case consultation before the pandemic was considered in person, billable, depending on the insurance company. A lot of Medicare companies pay for case consultations. Not Medicare, Medicaid, but you have to check. You may find the codes in the DSM-5 for consultation. Collateral consultation is on the phone or in a letter. They are not billable insurance through insurance companies. You will not find the codes in the DSM. And some clinicians have a written policy about charging for these. So a collateral is, well, a case consultation is, I don't know, they get so mixed up. Just call it case or collateral consultation. Because collateral is usually like anyone in the client's life, like a priest, a rabbi, a probation officer, a teacher, a guidance counselor. A case consultation would be a prescriber, a PCP, like that, okay, where the person is familiar with the clinical content of the case. Now, the reason for consultation. It can be one or multiple reasons for a consultation. It can be treatment planning, aftercare planning, assessment of additional treatment, clinical consultation. I get clinical consultation at least once a month. Treatment coordination, risk management, termination planning, or other such things. Okay, so I want to give you, here you need to have the parties involved, the name of the people attending. It could be a DCF worker and their relationships. And it could be at an IEP meeting. So it would be a teacher, a special ed teacher, a psychologist, a parent, a student, an attorney, a prescriber, a former therapist, or somebody you use for consultation. Would you need an ROI for any of the, or some of these? Yes, you would. Not for clinical consultation, not like supervision. You don't, because in supervision or clinical, once you're licensed, you no longer get supervision, you get consultation. So if you're going to another therapist for a consultation, you're not giving identifying information. You do not need an ROI. If you give identifying information to anyone, you need an ROI. Okay. Now, you also need a brief summary of goals, objectives, and/or interventions addressed and supported or reinforced during this consultation. I'm going to give you an example in a moment. That's a lot of talking. Okay. So an example. I'm going to give you an example from a case that I had when I worked at the agency. This is a client who had a primary therapist. She was referred to me for therapy because she was ready to work on her binge eating disorder. And I do a process, some mind-body work, energy modality work that can help address binge eating and other eating disorder issues. So I was doing adjunctive therapy. And, after, it was clear the client knew that's what we were going to be doing. And I had, one or two sessions where I took her history. I went through the diagnostic summary and thought I had a pretty complete history, and I had talked to the primary therapist, and I'm doing this process, this mind-body process with her that's supposed to clear trauma and traumatic stress without re-traumatizing. Now, this client engages in this activity and starts to sob. And it just completely breaks down. And on the outside, I'm like, really cool. But on the inside, I'm going, what the blazes is going on here? So we complete the process. She seems fine. She seemed to think it was a great session, but I'm freaking out. And I had time after that session. I called the therapist immediately, the primary therapist, and I had a conversation with her about it. And fortunately, I got her on the phone right away, which was, that's unheard of. And the therapist said, "Oh, don't you know she's got a terrible trauma history?" I went, No, she didn't say a word about her trauma history. "Oh, yeah. Oh, my God, this and this and this and this." I went, "Oh." Good God. So here is the reason for treatment. If we go back, well, no, let's just stay here. The reason for treatment, not the reason for treatment, the reason for the consultation. Client had an abreaction to an intervention, and adjunctive therapists wanted to discuss the reaction with primary therapist and develop a plan for how to address it. So there's your brief summary, right? And then how was it going to be addressed? The primary therapist said that she would talk to the client about why she didn't disclose anything about a trauma history. And this therapist, I would alter the way I used this mind-body modality to help instill inner resources so that she could actually do the work without falling apart. And, you know, had I not called the primary therapist and told her about this, there could have been a lot of questions had the client gone back and said, oh, yeah, I mean, it was really intense. And, you know, raised all kinds of red flags. So I was protecting myself and I was getting information to help the client. Does that help? Does that explanation help? Okay, I'm waiting for some answers. And I'm going to answer some of the questions. Good. Thank you for letting me know. It really helps. Really, really helps when you let me know. Beautiful. I'm going to take the time and answer some of the questions in the Q&A. Would this sample session note we are using be the form you use for the notes? No. It is not the actual form I use for the notes. It is a form that has the clinical information on it that helps you create the golden thread. There is a lot more information that you need to include in a session note that is not on this form. Those things, other things that you need to include in the session note were mentioned earlier at the beginning of the conversation or the section about session notes. Since your presentation has a focus on individuals in therapy, are there any recommendations for couples therapy documentation, or would it be the same? Really good question. I often address this at the near the end, but I will address it now. When you do couples work, most insurance companies do not pay for couples work, they pay for family work. They consider couples therapy like going to a workshop, like doing a woodworking workshop. I mean, it's ridiculous, but that's what they consider it. In order to bill for insurance for couples, for family work, you need to have an identified client or patient, and all your documentation has to be done under the name and diagnosis of that person, whoever is going to submit to the insurance company. They could have two separate insurances, they could have the same insurance, doesn't matter. Now, some couples therapists like to do extended sessions. So that means if you were to do an extended session, you would have the first 50 minutes under one member of the couple and 50 minutes under the other member of the couple, and you would have two completely different sets of documentation, and each one would be documented from that client's perspective. If you are when it comes to the quote, you would say something like per client and then write the quote. And then you could say per husband, per wife, per partner, then per child or son or daughter, and then write the quote. I hope that helps. Will we have access to a complete example session note and treatment plan? An absolute complete one using my forms that I have developed? No, I don't have samples to that because they are, they've taken really thousands of hours to develop. You can get access to them on my website, but I'm not going to talk about any more of that. You can email me any of your questions you may have about that, or put your email in the chat and I'll answer it in text or writing. Can you please review child-specific billing, such as family therapy versus family without client? That is too much of a billing issue. I would suggest you talk to your colleagues or a biller. There is somebody who does some wonderful billing work. You can find her on a Facebook group. She has her own Facebook group called, oh, I can't remember. I'm actually a member of this group. Her name is Kim Tolson, KIMTOLSON. And she has a program called Bill Like a Boss. I get nothing for this. I didn't even know I was going to say this. I'm just telling you, join her Facebook group. It's free and you will get a lot of help. I am hoping to be doing short-term therapy, ART, where most clients will be seen only 1 to 5 times for trauma. Sometimes it feels like I'm doing the treatment plan and paperwork will take as long as the therapy. Is there ever a time that a treatment plan would not be necessary? It is necessary with self-pay. I am sorry to say. One reason is they might be paying for it out of their own pocket initially, but they might submit it because they have a PPO where the insurance company will reimburse them for a percentage of what they paid you. And if the insurance company is paying the client back for a percentage, the insurance company can demand to see your note. The only time it is really not necessary to write a treatment plan is if the client doesn't show up. You know, if the client comes for 1 or 2 sessions and they're not, and then they say, this isn't for me, you just write a session note that says there was no need to develop a treatment plan. Well, now you're saying only seen for 1 to 5 times for trauma. 1 time, probably not, but I would have some kind of generic thing that I said in my session notes that documented why you were not writing a treatment plan. Or have a generic treatment plan that you use and tweak for each client. Yeah, Danielle Kepler is also good. Thank you. Okay. Would you write a consultation note while you were in supervision? Absolutely. I take supervision notes, but I never thought to include it as a consultation. Yeah, I do it all the time. If I'm a former therapist of a client, then what are my obligations to document that, assuming discharge and termination was normal? I don't know the answer to that, but to be on the safe side, I might just throw it as a consultation note in my, that's a really good question, Jason. I've never had that question before, and I have not faced that situation before. But to be on the safe side, I would do it. And one of the reasons I would do it is because if the therapist or whomever consulted with you and said one thing about the consultation, and it's not what you remember, you don't have it written down, so you can't validate it. Yes, I'm going to discuss ways to document longer sessions, not specifically family, but I will talk about 90837 soon. If you go to a clinician for supervision, do you need to document? No. If you're working for the same practice or agency, would you still need an ROI if you're consulting with a colleague? No. If you are not revealing identifying information, you do not need to get an ROI. All right. I am deleting these questions. So if any new ones come up, I won't have to scroll through to find them. All right. Now, discharge summary. Hold on one second. All right. We are going to talk about the discharge summary, and then we're going to take a break at 20 minutes after the hour. So that would be 20 after 1 Eastern time, or right around 20 after 1. All right. I know it's a long day and you guys are doing fabulously. Do I have a consult for every patient? Only the ones I need them for. I definitely do consults with prescribers, particularly if there seems to be an issue with medication. And I do consults with PCPs because a lot of my clients are very overweight. And the first thing that the PCP says to the client is, you know, if you lost weight, you wouldn't have this problem, which may or may not be true. Everything is blamed on a client's weight. You can miss cancer blaming it on the client's weight. So when I have a client who says, no, I'm not going to see my PCP. I don't like to see my PCP. Well, why? Because I always feel terrible when I leave. Then I have a consultation with the PCP and we talk about how to have a conversation about the client's issues, the client's medical issues without blaming everything on their weight. And then how to have a conversation about weight that is not shaming. So, and I document that. All right, a discharge summary. It is a review of the treatment plan, and it includes problems, goals, and progress. So if you look at my discharge summary, it looks a lot like the treatment plan, but it includes additional data. It's missing some data, includes other data. So it has the discharge date, the reason for discharge, the client's response to meds, other agencies or providers notified, involved, and notified. It also includes discharge and follow-up recommendations. Remember I said that I had this slide in at the beginning and it belongs here? This is where it belongs. Condition at discharge. What is the condition at discharge? Now, you may not know the condition at discharge. The client may what's the word? The client may have stopped seeing you and just stopped showing up. So you don't know. It could have been several weeks. And so what you write is, it could be a no-show. Exactly. So what you write is condition of discharge unknown due to no-show for X number of sessions. Or you could write condition of discharge at last session was, or condition of client, condition at discharge at session dated January 2nd, 2020 was, or you can say condition at discharge, client completed goals, client completed X goals, or and did not complete. It's like progress, client did this, did not do that. Follow-up recommendations. Oh, wait a minute, I'm missing something. Condition, reason, diagnostic summary. No, come on, Beth. I know why. I really mean to talk about these a little more in detail before I jump to that. So let's go back to this. My apologies. The discharge date. Of course, it needs a discharge date. That's the date you are finally discharging the person. That is not the date you last saw the person. That's the date you're discharging the person. The date you're discharging the person may correspond with the last date, but that's only if you have discussed the discharge and had a termination session. There's lots of reasons why the last date of service will not be the discharge date. And that comes down to reason for discharge. The reason for discharge could be that the goals were completed. It could be a therapeutic breach, that they found the client and therapist were no longer a good fit. You would need to describe why. It could be that the client moved out of state. It could be that the client changed insurance companies, lost job, decided they didn't want to be in therapy anymore, has a job that requires too much travel. Could be a lot of different reasons. The response to medications. Now, if this is a planned discharge and you know the client's response to meds, then you can write it. And this is one of the reasons it's good to keep track of response to meds in each session note. So, client's response to meds. Client reported meds were very useful and had no adverse side effects. That's a good response. It could be client was consistently inconsistent taking meds and did not seem to get the value that she could have had she been consistent. Response to meds is whatever the response is. Other agencies or providers involved and notified. You best believe it, when I had to discharge my client who had that abreaction to the mind-body modality, that I got a hold of her primary and I let her know. This is what happened. I was at the agency. My role at the agency was changing. I was taking on more supervisees and fewer clients. And I had to discharge some of my clients to make room for my supervisees. So, it was like, King Solomon. I had to decide which clients to let go. It was a hard decision. But I based my decision on who was in the most need and who had the fewest supports or the most supports. So I discharged this client who had this abreaction. And let's go to the next. And I informed her primary therapist. Let's go to the next slide. So the condition at discharge, what I wrote was why the client was being discharged and that she was very upset because she felt she was making progress. But I explained my rationale. I documented how she felt about it. And I had also documented that I had conferred with her primary therapist. The follow-up recommendations were to find a therapist who could do a mind-body modality with her to address her binge eating issues, and that this therapist was working on finding someone for her. I also put, by the way, in my reasons, in my condition at discharge, my reasons for discharge. And that was what I explained to you, that this therapist's role at the agency was changing, that the client had multiple supports, including a primary therapist, a group therapist, a group, she was in group therapy, DBT therapy, and was an active member in her church. She had a lot of supports, and she volunteered at a animal rescue thing. So I just was very, very thorough. Not all discharges need anything that thorough, but because this was an unpleasant one and a difficult one, I made it very thorough. Was client informed of discharge? Or and so the answer is yes, the client has to be informed of the discharge. Is it by letter, phone, during session, or other? Now, other, I suppose, could be text, it could be carrier pigeon, if it's a planned discharge, then it's during session. When this therapist had the problem with the client who threatened to report her, the therapist said she terminated by phone immediately. And that was documented in the discharge summary. It is not mandatory to write a discharge summary for most insurance companies, except probably Medicaid companies. However, a discharge summary will cover your butt. Also, write a letter. Even if you've discussed it by phone or video or during session, send a letter. And when you send a letter, send the letter with other options. Not other options. What am I trying to say? Send the letter. If the client is terminating therapy before therapy is completed for any reason, give 3 referrals to that client for other places or other people she could go to for therapy. Whether you're referring to Psychology Today or any of those other new ones that are coming out. But particularly if it is a client you're concerned about, make your referral specific for the client's needs and the type of therapy they need. This will protect you. It will help the client in getting an additional, in getting a therapist if the client wants one. It protects you, that you have done your due diligence. Yes, it's time. Yes, it can be annoying, but you've covered yourself. I skipped follow-up recommendations. Follow-up recommendations are things like re-engage in therapy if and when needed and wanted. It's also continue taking medications as prescribed, continue using goals developed in therapy or in treatment. Whatever your thought, continue going to AA and using supports. Continue mindfulness practice and bringing compassion to self. Whatever your follow-up recommendations are. Okay, Jessica, I'm not exactly sure what you're referring to. In private practice settings, that does not take Medicare or Medicaid. I am not sure that it is needed to finalize discharge with a patient who no-shows. The exception would be any case that has litigious type of situation or high risk. Would you agree? Yes, I would agree. I said a little earlier, it is not mandatory to write a discharge summary except for Medicaid, Medicare, but it is smart. And particularly in high-risk situations. And you don't ever really know when it could be a high risk. Frederick, that's something you're going to have to take up with Drew. Do you have thoughts about notifying client by use of a patient portal? Yeah, that's email. Letter, phone, during session, other, email. I would highly recommend not doing it by text. I mean, you can write your follow-up letter, your discharge letter in an email, but make sure that it's an encrypted program or a portal, because that is not something that should go, that should be easily hacked. If you get a breakup text, and who has not had a breakup text? If you get a breakup text, you should document that, the date that you got the text, and even if you want to, the time you got the text. Writing a discharge letter. Oh, when do you discharge somebody? How long do you wait? Ah, yes, there's the question. Is there a time frame? That's always the next question. So, how long you wait to discharge somebody really depends on how big a risk you are willing to take. When I was new and I had a client who no-showed me repeatedly and every once in a while would show up, I kept thinking to myself, if I'm good enough on the next session, she'll show up. And I thought it was me. And I was going to her house. So you would think she would be there. And she didn't show up for weeks and weeks. And, eventually I got the idea, and it took too long for me to discharge her. I think I discharged her after 2 months. I think that's too long to wait. You need to have in your consent for treatment or your office policies what your conditions are. Like if there's, if you have X number of no-shows or X number of cancellations within a given period of time, what your policy is. And then you stick by your policy and you say, if you do not show up for 2 consecutive appointments, you will be discharged from therapy. Whatever it is, you need to have it documented. And then I would recommend sticking to it and not thinking that you will be the savior for this client. This will protect you legally. What happens if you don't have a discharge summary or a discharge letter and your client winds up in the emergency department? Let's say they've OD'd and they wind up in the emergency department and somebody says, listen, you need to see a therapist. Do you have a therapist? And the client says, oh yeah, my therapist is Beth Rontel. And you have not seen this client for 3 months, 6 months, a year, and you don't have a discharge letter or a discharge summary and a discharge summary, I should say a discharge summary or a discharge letter, you could be held liable for that client, and you don't want to be held liable for that client. Are there any questions about a discharge summary? A discharge summary is not a billable service. No paperwork is a billable service. That, yeah, that's a bone of contention for a lot of people. When you're a fee-for-service clinician or in private practice, you do not get to bill the insurance company for the time it takes you to write your notes. You know what? No provider gets to bill for the time it takes to write their notes. every provider I know, whether it's a PCP, a cardiac surgeon, a chiropractor, they all have to write notes, and none of them get paid for the time it takes to write them. A lot of people do concurrent notes. I don't. I'm not good at it. I can teach people to do it. I just don't like to do it. The one piece of concurrent note taking I would do, and do often do, is say, is say, how was this session for you? What did you get out of it? What can you take from this session and use during your week? And for me, that's concurrent documentation, because that's homework in progress right there. And I am going to suggest to a friend of mine, another clinician who has clothes for therapists, that she needs to have a T-shirt that says paperwork is not a billable service. I think that's brilliant and wonderful. So thank you, Brenda. Yeah. All right. Any other questions? Anything more about anything so far? If I'm going to talk about it in the red flags section, I'll let you know. But anything so far about anything we've covered? Let me check the Q&A. Whenever there is a discharge summary, there needs to be a discharge letter. Are there instances when it's not indicated to send a letter? No, it is always you always send a letter. And if the letter comes back returned because the client has moved and left no forwarding address, scan the envelope that says no forwarding address, so that in case you have a legal issue, you're covered. I know it's a pain in the butt, but it is a bigger pain in the butt than, but a bigger pain in the butt is having a legal issue and you can't protect yourself. Is there a sample? Ken, I'm not sure what you mean by a sample of what. I've referred to a lot of things. Do you write during session on templates or a notepad? I can't remember if I don't. Oh, yeah, I can't remember from session to session. Like I said earlier, I often rely on what I, in today's session, what the client said in the previous week, and sometimes actually read it verbatim. I mean, I don't write a big long narrative, but I will just, write key words or key phrases. Those don't go in the clinic, in the progress note or the medical record. But yeah, I write during session all the time. And if you want to write your notes during session, whether you handwrite them or use an iPad or something, that's up to you. It's not something I'm comfortable doing, but I know therapists who do it. In regards to verbiage, is there a book you would recommend? I don't recommend any treatment planning book. I recommend that you develop prompts for yourself, that you write out a list of your most common interventions, and you keep it either on your desktop, your computer desktop, or your hard copy desktop, your hard desktop. And when you're trying to think of the interventions that you've done, you just look at your list and see if one of them is there. And if not, you make one up, and over time, it will just start coming to you. If you want to use a treatment planning book, in the bibliography and the citation page that should have come as an attachment or been included at the end of your manual, I believe I recommend John's. I don't recommend. I believe Johnsma is there and how to get it. I don't even remember the name of it. Like I said, I don't use them. I tried when I was a new clinician thinking that it would be the answer to my prayers and found that I was uncomfortable doing it. I didn't really understand how to do it. Okay. So whenever there is a discharge summary, there needs to be a discharge letter. Did I just answer that? Are there instances when it's not indicated? I think I just answered that. Did I? Oh, geez. A long day, everybody. Janice, let me know whether I answered your question or not. In the meantime, I'm going to answer another question. Is there a sample discharge summary? I provide samples, completed samples in my clinical forms package. That is a whole other conversation that we are not going to have. If you want to know about that, contact me individually, please, by email. You can either do it through the email that you'll see at the end, or go through my website and send me a message. Are there any confidentiality concerns with sending a discharge letter? Yeah, there are. Yeah, there are. I don't know how to, that's why we have to be careful in what we write. When you are writing in a session note and your client divulges that they've been having an affair, or another client divulges that they've been having unprotected sex with multiple partners and it's a teenager, you want to be really careful how you write that. Because that will violate confidentiality. Do you have a record review tool? Yes, I do. I use my record review tool when I review people's treatment plans and session notes. That's a great question. I bet, who asked that, Frederick? I bet that you are a supervisor of either a group practice or at a clinic, because that's how I learned that it's important to have a tool. Thank you, Kenneth, very much for your kind words. So when we get proficient like you, how long does it take to do a progress note? 3 minutes if it's simple, 5 minutes if it's 5 to 7 minutes if it's a little more complex, 10 minutes if you really have to think about it. I would bet that that's shorter than than the time most of you spend writing notes. That's if you have a good template, a template that cues you to include everything you need. So you're not faced with an empty box that says clinical content and you go, what is the clinical content? I mean, you can train yourself to think what the clinical content is, but if you have something that cues you for all the clinical content, it will become second nature. Will I be weighing in on the electronic practice management systems? Absolutely. At the end. Thank you. Okay, I've answered your questions. Excellent. So, good. Okay. I am deleting so that I can proficient. Hello. All right. Any other questions? No. Let's go on to diagnostic summary. All right. So the purpose of a diagnostic summary is to establish effective communication between provider and patient. That is the purpose of gathering all the data in order to formulate a tentative diagnosis. And now I say tentative deliberately because a diagnosis can change. Remember, in the interview, we started out with adjustment disorder with anxiety, and had this go on for longer than 4 months, it would have been probably generalized anxiety disorder. So yes, a tentative diagnosis. And if you're unclear at the beginning and need to and want to bill right away, just use adjustment disorder until you're clear about the diagnosis. Okay. The purpose is also to determine medical necessity and as appropriate, initiate an effective and comprehensive treatment plan. It is an integrated and complete biopsychosocial and medical assessment with a tentative review date, and that is by the Center for Medicaid and Medicare Services. That's their definition of a purpose for diagnostic summary. All right. What is needed in a diagnostic summary? Well, of course, the name and the client number. Again, the client number is not mandatory unless you're in an agency or you have a lot of people with the same name and birth date. You need the gender. Now, notice I did not say sex, I said gender. So we also need to be culturally sensitive and diversity sensitive. Marital status, date of first service, the current life situation. In other words, with whom does the client live? The family, do they live with family? Do they live with friends? Are they living alone? You want to know if a person is involved in any clubs or organizations, including churches, temples, mosques, and the importance of those organizations to them. This will tell you whether they are socially engaged or not. Now, I used to have one client who, when I asked this question, are you a member of any clubs or organizations? I think she listed 12 organizations she was a member of. They were all work-related. And what that told me was that she had no social life. And that was confirmed, that she had no social life in our work together. And that was one of the reasons that she would binge eat, because she had no other pleasures in her life. Are there other agency involvement or any other provider involvement? You want to know this because you may need to be in touch with them. And if you need to be in touch with them, or even if you don't, you want to get an ROI or a release of information. You want their developmental history. Now, you might say, well, what's included in the developmental history? I include, even for adults, whether they walked, talked, toilet trained, on time, early, or late. Now, it's in quotes because, what does on time, early, or late really mean? There are prescribed, I don't know what the words are. There are the prescribed times that people say, you should be walking by this time, reading by that time. So I like to find out, how long the client crawled for, if they know. Or when did they start walking? And if the client said, oh my God, my mother said I started walking when I was 9 months old. And I'm thinking, oh, whoa, we may have ADD on our hands. The reason this client is having problems focusing and getting anything done could be ADD. Now, why am I already thinking that? Because I know that crawling creates the right-left crossover, right? You're doing this. So that's the right-left crossover is happening in the brain. The longer a kid crawls, the more crossover is happening with the arms and the legs. So the less crossover, the less time crawling, the less crossover, the greater the chances that this person might have ADD and I have diagnosed a lot of adults with ADD partially by getting this information. Now, I'm not going to tell you if a child crawls at 9 months, that they are destined to have ADD. No, this is part of a bigger assessment, but I'm telling you why I take a childhood development history even for an adult. I want to know if the child was a preemie because there could have been birth trauma or nonverbal developmental trauma, being in an incubator without any touch. And then what? How do you deal with nonverbal or preverbal trauma? I mean, there are ways to deal with preverbal trauma, but this is what you want to know if you need to do that. So I take as thorough a developmental history as I can. You want to know the client's education. You know, what's the highest level of education the client got? And you want to know if the client has any legal issues. Some therapists don't like to work with clients who have any legal issues at all. And that's understandable. So that might even be part of your initial conversation before you even accept a client. Do you have any illegal issues? And if so, what are they and where are you in the process? If that's in your intake and you think to yourself, oh, this is a client who's involved in a bitter divorce and custody battle, and they're going to want me to testify as to who should get the kids. I don't want to be involved in that. You can just say, you know, after our conversation today, I think I'm probably not the right fit for you. You need somebody who really specializes in X, Y, and Z. Every time I have not followed my gut around that, I have paid the price. Having clients for whom they say things to me and I'm thinking, this is somebody who I don't really think I'm a good fit for, and I take them anyway. It almost never works out. All right. Now, I happen to like working with client with certain legal issues. I have two of them right now. I like the legal issues, but you need to be careful when documenting legal issues. You cannot even come close to consulting on legal issues. You can only talk about how it is affecting the client emotionally and behaviorally. So I write something like, let's see. The client comes in saying, I'm really freaked out. The court case, we go to court on September 8th. I'm really freaked out about it. Well, we don't talk about legal strategies ever. And I'm very clear with the client that we don't talk about legal strategies. But I will say, how are you feeling with it? How are you doing with it? What are you concerned about? Oh, that's something you should take to your lawyer. Well, this is something I can help you with. Oh, you're concerned that you might get triggered when you see the abuser in the court. Okay, let's talk about how you can deal with that. Let's teach you some grounding exercises you can use with that. Let's come up with what you might look like and how you can inform your attorney so your attorney can help bring you back. Now, that's not a legal strategy, that's an emotional strategy. How do you deal emotionally with being in court? So you want to know what you're getting into, all right? You do want to know vocation, not a big long resume or CV, just, what do they do? Are they employed? What are they doing? You might want to know if they have a history of unemployment, if they're on SSI or SSDI, and when they started that. And maybe even whether they like their job or not, or how they feel about being on SSI or SSDI. Military service. You want to know if somebody's had military service, and then you will want to know what their discharge was, and what role they played, and if they saw active combat. Now, you can pretty much guess why I'm saying this, but I want to be really clear. If they have seen active combat, it doesn't mean that they're going to have PTSD. Most people who see active combat don't have PTSD, but there are plenty who do. So you want to find out, and you want to assess for it. And there are people, we know a young man who was in the military, who never saw active combat, but he processed all the discharges, and he saw all the pictures and read all the stories and has PTSD from that. So find out a person's military history. And I never would have known by looking at him that he had been in the Army. It was only by having a conversation. And this wasn't even professional. This was personal. All right, you need the PCP and the prescriber name and contact info. It is absolutely required, and you absolutely want to have it because you want to be able to easily connect with that person. You want to have the meds. Now, in the diagnostic summary, you actually need more than psych meds. You want to have all the meds. On the treatment plan, you want to have the psych meds. You want to document illness and allergies. Illnesses and allergies can affect a person's mental health, so it's really important to know about them. Sometimes illnesses and allergies are brought on by emotional issues. The mind body are like this, right? So there are some therapeutic modalities that address the mind-body connection to the illness or the allergy. It can be very helpful knowing this. Also, if a person has an allergy to a food like nuts, tree nuts, and you're a therapist who keeps tree nuts in their drawer to snack on between clients, you want to make sure that you don't do that right before this client comes in. So it's very helpful to know what the allergies are, and it's mandatory to know what illnesses and allergies are. You want to know the mental health history, particularly if there's a history of hospitalizations and suicidal ideation or attempts. You want the current symptoms. Now, if you just have a place for client to write out current symptoms, your chances of getting a list are not good. I will tell you that, because I do have a place for people to write out current symptoms, because I send them my diagnostic summary and I say, please return it before the first session. And almost nobody fills it out. But I also send them a 25-item symptom checklist, and that gives me a lot of information because they don't have to think about it. They can just check off boxes. Well, once you get the current symptoms, you then can ask the questions that lead to the behavioral representations or manifestations of the symptoms. You want a family mental health history. And you want a family mental health history because mental health disorders can also be inherited. And you also want to know what the client grew up in. All right. You want a trauma history. Now, when I'm talking about trauma history, the reason this is starred is because trauma comes in lots of different forms and flavors, as we have really learned the past several years. There's bullying. I mean, there's not just domestic violence, which is, I don't mean just by any means, but there's not just domestic violence, sexual abuse, physical abuse, emotional abuse. There's bullying, there's racial profiling, there's other forms of discrimination, there is sexual harassment, homophobia, transphobia, violence towards LGBTQ, immigration issues, and fat shaming. Now, I'm sure you can come up with some others, but you want to have a diagnostic summary that has a template for all these, because whether you fill it out and ask the questions, or you give it to your client to answer the questions and you give them cues for it, they will say yes or no. But if you just leave it blank for trauma history, they may not know what you're talking about. Substance abuse or use, a substance use history. I actually include a fairly extensive one in my diagnostic summary. Risk and mental status. It's the same risk assessment that we saw in the treatment plan and the session note. Any other information not yet mentioned? Now, I have this as a section because you don't know what's happened in a client's life. Like, did the client have any particular losses? Did their mother die, their father die, an important grandparent or friend? I had 2 clients whose houses burnt, were decimated by fire. That's a really significant trauma. And so I just have a section that says important information not yet mentioned. I had a client whose brother had cerebral palsy. She grew up with the brother having cerebral palsy, and then he eventually died. What's really interesting is that when I was supervising, I supervised a therapist who was the therapist for her parent. That was really interesting. So I actually knew when her brother died. So any other important information not yet mentioned? And of course, the reason the client is seeking services. Now, this is a very, very quick statement. This reads like the answer to a 7th grade essay question. The reason client is seeking services or seeks treatment is because, or is to, or client reports being very upset or being the primary caretaker of her parent and is high and reports being extremely anxious and wants help dealing with her situation. It's very simple. Okay. It's not your big long reason. That reason client is seeking services is backed up by all this other information. All right. There's a question that says, how is the diagnostic summary different from the intake assessment? It's not. They're just called different things. Do you ever take a direct quote for the reason? Yes, I do. I notice that you don't mention how they are referred. That's a great comment. On my intake summary or assessment, I actually have a section that includes who referred you and contact information, and may I contact that person to thank them for their referral. Okay, you want to know if there are family supports or any other kind of supports. Asking about family supports will really tell you a lot about the client's relationship with their family and attachment issues. Clients' strengths, motivations, and how they will be applied to treatment. Insurance companies want to know all of this stuff. And it's really important to have clients' strengths and motivation, because clients are supposed to be motivated in order to justify medical necessity. I remember being an intern, and in my notes, I focused a lot, and in my supervision, I focused a lot on what the client's problems were and the diagnosis. And I am forever grateful for my supervisor saying, "Beth, why do you always pathologize everything?" And I went, "What?" She says, "Look for the client's strengths and build on them and find out how they're going to use those strengths to help them get through their lives." Okay. That 60 seconds transformed my relationship to providing therapy. You want to get the barriers to treatment. Now, this might be that you are simply listening to their story, like we listened to the story on the video, and we found out that there were no supports at work and no training. You might even say something like, "Is there something that would keep you from getting to your appointments?" Now, this client I talked about who came to see me for adjunctive therapy, she lived 50 minutes away, and she had to take something called the ride to get to me because she had no other transportation. I don't know what it's called in other states. In Massachusetts, it's the ride. It's public. It's not public transportation, but it's a public service type of transportation that you apply for. Well, sometimes the ride is late, or sometimes they don't show up. So that was a potential barrier. But you might say, what would make it hard for you to be in therapy, to do therapy? Do you have any concerns about therapy? Okay. And of course, you have your diagnosis or diagnoses with the name and code and the severity. Then you want to have your treatment strategies. This is not your plan. You're just going to say, basically, using XYZ modalities will use XYZ modalities to reduce blah, blah, blah symptoms and improve blah, blah, blah functioning. That's your treatment strategies. But what you're already doing is thinking about your treatment plan. And then you need your signature with licensure and date. So there is a question here from Amy that says, "I collect a lot of this information from client through my portal. Do I need to type everything over in my own separate report?" Well, Amy, I don't use, I don't know exactly what you mean by your portal, because I don't use a practice management system. I'm a little old school on that, and I apologize, but that's me. If you mean, such as therapy notes, yeah, I understand. That's a practice management system. Simple Practice, Therapy Notes. I can't remember the names of the others, but those are the two main ones. I believe that it's there. If it's there in your portal, it should be there. But I think that is a I don't think you need to type it over in a separate note. You just want to make sure that all those questions are in that form that people answer through the portal. So if you mean your forms go through your portal, then it is part of your records. Yeah, I think that's right. If your forms go through your portal, it's part of your records. Okay. Here we have medical necessity. This is the review. Okay. You start with your diagnostic summary, which we just completed. You use that information to write your treatment plan. You base your sessions on what the treatment plan is, remembering that things go like this and they're not linear. So don't freak out if it doesn't follow your plan perfectly. You make sure you write your case and consult notes and generally write a discharge summary. Do good billing and coding. Make sure it all matches. I'm going to talk about that in a minute. You create your golden thread, which creates clinical relevance, and that winds up being a contribution to clinical care, not a distraction or could be an annoyance, but it's not a distraction to clinical care. And you have protected yourself. Okay. All right. We are absolutely on the home stretch. 26 minutes to go. So, big stretch. And we're going to go into red flags and fraud. Did we already take a break? I can't even remember. Yes, we took a 15-minute break. That seems like 3 hours ago. All right. Red flags and fraud. There's a lot of them, and I'm going to go through them relatively fast. Adjustment disorder is dicey to use. Don't use it more than 6 months unless you can justify it. There is such thing as a chronic adjustment disorder. It's totally reasonable to have a chronic adjustment disorder. I know a woman who has a developmentally disabled son. Her son is like 30 or 40 years old. She's in her 70s. She's been in therapy for 30 or 40 years to help her deal with all the different developmental stages that her son goes through. Perfectly reasonable. I once did a 4-year retrospective audit review for someone. I helped her with a 4-year audit, and she did everything beautifully. She transcribed her handwritten notes into the notes that she got from me, into the templates. And she did everything beautifully, but we were concerned that she was going to fail this audit because she diagnosed the person with adjustment disorder. However, and this was a Medicare audit, however, she passed this audit 100% because every year she could justify a major adjustment this person was going through. It is risky to use an unspecified disorder for an extended period of time. By definition, unspecified means that they do not have enough criteria to meet an actual mental health disorder. Most unspecified disorders are used for emergency departments. That doesn't mean you shouldn't use it. It just means be careful of what you're doing and make sure you justify it. If you can't find enough, if the person doesn't qualify for panic disorder or generalized anxiety disorder, but they qualify for anxiety disorder unspecified, then what are the biopsychosocial stressors in their lives? What are the barriers in their lives? Use those to help justify continuing to use the unspecified disorder. By the way, I wrote a blog on this, and I wrote a blog on self-esteem. Do not use poor self-esteem as diagnostic criteria in your treatment plan. Even though poor self-esteem is diagnostic criteria in in dysthymic disorder, you can use it as the diagnostic criteria, but you can't use it as the behavioral example. You've got to describe what poor self-esteem looks like. Here's why. I was once supervising a very competent therapist who was working with a teenager, and on her treatment plan, it said poor self-esteem. And I said, well, what does poor self-esteem look like? What does it make her do or not do? And she said, oh, she sleeps with a ton of guys all the time. She doesn't care about her body. She doesn't care about herself. Her self-esteem is terrible. Oh, well, now that's clear, right? Poor self-esteem as evidenced by, you might be careful about saying multiple sex partners, but risky behavior, risky behavior and lack of self-care. This same clinician came to me, and I was reviewing her treatment plan, and she had poor self-esteem about this guy. And I said, well, what does poor self-esteem look like for this guy? And she said, oh, he feels so bad about himself. There's a job opening. There's a job he wants to apply for where he works that would increase his salary, but he doesn't think he's good enough to get it. Well, it's a very different presentation, right? So poor self-esteem doesn't mean anything unless you describe it, and insurance companies will not reimburse for it. For Medicare, psychotherapy does not include teaching grooming skills, monitoring ADLs, or social interaction like art, play therapy, and socialization when these are the only services being provided. Now, I know plenty of wonderful art therapists who provide art therapy in session a lot. I supervised one who I just thought was fantastic. You have to relate that art therapy session to the mental health diagnosis, what you're doing and the behaviors that you're working on, and the cognitions that you're trying to change, and the insights that you're developing. Okay, it can't just be play or art therapy. And ADLs and social interactions, you can address them in therapy, but if that's all you're focusing on, what they need is a caseworker or a therapeutic mentor. Document the start and start time of each session. I'm just repeating it because it's so important. That is a major documenting error that will incur a clawback or a recoupment. Sign and date your records with your licensure. That is another problem. If you don't sign it with the date and your licensure, it could incur a clawback or a recoupment. A dementia client's records should support that the cognitive level of functioning is sufficient to permit the client to participate in a meaningful treatment. Okay. So what is all that about? I'm sure there's a number of you who work with the elderly and who work with clients who have dementia. First of all, if you have a client who has dementia, you absolutely must take a mental status exam every time. Because you have to prove that the client is able to participate in meaningful treatment. You also have to be careful about it and not jump to conclusions. This is a scenario I learned from one of my participants in an in-person group. She said, I was working with a client who has dementia, and there was another therapist working with the same client. And this other therapist said that the client was not able to function and participate in meaningful work. And she says, but I got her to. So what do I do? Well, first of all, I told her you document that what you did and how you did it, and the client's able to participate in meaningful work. And that's why you need to be reimbursed. And the other therapist has other problems. Just don't jump to conclusions. if you get this client from somebody else and it says, inability to participate in X, Y, and Z, don't assume that's right. Okay, group therapy documentation needs to include a short version of everything we covered in the session note, and it's supposed to be written after each group therapy session. Now, I have tried to develop a group therapy note, one template that covers all different kinds of therapy. I have not succeeded yet. Not all different kinds of therapy, all different kinds of groups. I have not succeeded yet. And I ran groups for a long time. I ran therapy groups for a long time, called Making, it was around food issues and body image issues. All right. And yes, I did write it after each session, but it was very brief. Treatment plans should be reviewed and signed by the therapist and generally signed by the client and updated when necessary. It is not mandated that clients sign treatment plans for every insurance company. Blue Cross Blue Shield of Massachusetts does not require a signed treatment plan. However, it's a really good idea to go over the treatment plan with the client and document that in your session note that you did that. And for those of you who do need to get a signed treatment plan and you don't use hard copy, if you use a practice management system like Therapy Notes or Simple Practice, and I'm not endorsing either one of them, either print out your treatment plan and have the client sign it and then upload it so that you have a record of it, or find a way to get an electronic signature. Treatment plans, ideally, I've said this before, every 3 months, but the clinic where I used to work at got it extended to every 6 months. Private practice therapists are required yearly unless there is an update needed before then, like the treatment has really changed course. But you can have a treatment plan that changes course. We just experienced a lot of that at the beginning of the pandemic. So you can have a treatment plan that changes course without having to rewrite or update your treatment plan, as long as you write it in your session note that the plan has changed to XYZ due to XYZ. An example. I have a section in my session note template that says recent significant events that may affect treatment plan. And then we stopped going to the office on March 14th. And every one of my clients, as well as me, as well as I, was adjusting to the pandemic and adjusting to video sessions and adjusting to staying indoors and adjusting to everything and still dealing with all the other things they had to deal with. Well, maybe not all, because some of them didn't have a job. So then they were dealing with not having a job. So that's an abrupt change in treatment. So when I thought it was going to be temporary, I wrote increased social isolation due to pandemic, increased anxiety due to pandemic, and that we were going back to focusing on skill use rather than dealing with trauma. Okay. If you want, though, you can write an addendum to the plan, or you can rewrite your plan before the year is over. Somebody wrote a question or a comment earlier, and I didn't answer it because I'm going to answer it. Oh, wait, I'm not going to answer it now. I'm going to answer it later. It actually comes up later. All right. Service codes used in claims for payment must match the codes used in the progress note. So in other words, the service codes, you need the service codes, 90834, 90837, or whatever it is for family, or 90836 for the really short session. If you've got it on your payment sheet, on your claim, it needs to be in your progress note, and it needs to be the same thing. It's the ICD billing. It's your billing code. Okay, you want to have them there. They need to match. If they don't match, it's considered fraud. All right. So I'm seeing a lot of people putting their email addresses in. Thank you. This is where to put them in. This will make collecting the email addresses much, much easier than culling through all the comments and pulling them out. Thank you very, very much for doing that. You will get everything we talked about in an email in the next day or two. So keep putting them in. Inaccurate charging. In other words, billing services coded at a higher level than furnished. Okay. Don't bill an individual session when you're providing group treatment, and don't bill for a progress note when you're doing a collateral or a case consult. Now, I would wager that there's nobody in this training who would do that because you're interested in doing the right thing. But if anybody supervises, be wary. It happens. I supervised for 11 years. I supervised over 50 clinicians. I know it happens. And by the way, it can happen by accident. I normally bill 90837, and I leave I normally bill 90837. Occasionally, I bill 90834. I'm late. The client's late. The client just doesn't want to do anymore. The client wants to end early, and we've got the 90834, and it's fine. It feels like the right timing. But you're used to billing 90837, and you bill 90837. But on your start and stop time, you don't have enough minutes to verify the 90837. And you've actually indicated that it's 90834, but you're not looking at your session note when you're billing, you're going by your memory. So it can happen. Is there a service and billing codes for telehealth? Yes. It's not a service code, it's a modifier. There are other people who can answer that in the chat, I am sure. Frequent revisions of entries. You can make revisions of your entries. If they're handwritten notes, then use blue or black ink, strike out what you are getting rid of with one line, add what you're adding, and initial it. If you are doing it in your practice management system, it will mark the time for you. But if you have frequent ones, if you're always going back and making changes, it's a red flag. Why do you need to make so many changes? You shouldn't. If you do things the right way, you shouldn't have to. But if you do it, make sure in your practice management system you say addendum or revision, and then say what that revision is. I just consulted with a clinician who had a 6-month Medicare review, and she did a ton of addendums and revisions in her treatment plans and her session notes. I could never quite get the reasons why she was doing them, but she couldn't she couldn't explain the reasons for why she did them. And that caused all kinds of problems. It took us hours and hours to figure out how to address this problem so that it didn't look like fraud. Now, here's one of the basic reasons it didn't look like fraud. all of these revisions and addendums were done before she got the audit letter. If they were done after she got the audit letter, it would have looked like fraud. But what we did is went through it all and figured out what they meant and explained it all in a cover letter. But I mean, she spent a lot of time and a lot of money going back to correct something that didn't have to be in the first place. You can commit fraud even if you don't think you are. It can be an accident. It doesn't have to be intentional. So I'm going to say something that can scare you even more. Not only might your license be revoked, you could go to jail. You have to be really, really bad to go to jail. But, you know, it happens to some people. Where can you get the list of how many minutes for each session? You can Google it. Symptoms and treatment must support the diagnosis. I went over that in much more detail earlier when I was talking about diagnosis. I just want to kind of drive it home. The symptoms and the treatment need to support the diagnosis. This is one of the other top reasons cited for not passing an audit. Missing entries, including no-shows and cancellations. Ooh, you want to document no-shows and cancellations. This will cover your butt legally. And you want to include, when you do this, did you reach out to the client and how you did and how you reached out and why there was a cancellation? Did you cancel? Was it a therapist cancellation or was it a client cancellation? Was it last minute? Did you offer a rescheduling option or not? Was the client able to reschedule? I mean, I have a 48-hour cancellation policy. And I always tell my clients, whether you cancel 10 minutes before your session or 3 weeks before your session, if I can reschedule it with you for that same week, if they're weekly, I will do that, because I don't like to charge anybody for something they didn't get. But if I can't, I will need to charge you. And then, of course, I give them the exceptions, like, you know, unexpected events, like going to the hospital, a death, you know, those kinds of things. But, you know, headaches are not a reason. Even snow emergencies are no longer reasons, because we can do telehealth for most insurance companies. Okay, session notes should always be written after the service is provided. That seems like it is very obvious, but it is not very obvious. It's a sad state of affairs. When I was supervising, not my supervisees, but I noticed there were therapists who were writing notes before they saw the client based on what they thought the client would do. They did it because they had time and they didn't want, you know, and they just wanted to be done with it already. And they were very cookie cutter session notes. And you could kind of tell because they read like the previous note. So I'm sure nobody in this training does that, but I am sure that if you supervise, you have some people who do that. It is very sad. Never bill undocumented services. Bill your service after you write your note. Motivation for writing a note goes way down after you have billed your service. It's so hard, and then you get behind. And then it's even harder. Now, I am not a paragon of virtue. I used to be. But between my clinical practice and my documentation work, I'm busier than I've ever been. And it can be very difficult to keep up. I don't bill unless I've written my note. So, because otherwise, even I, the documentation wizard, would say, no, not this time. It's fraud. All right. Don't do it. No overlapping services. That is possible. It's usually a mistake, but not always. You know, if somebody, here's where it's not always a mistake. You have someone who, a therapist who has two clients with different insurance companies, and they are billing for a service they did not provide. And they bill at the same time, but different insurance companies. The chances of that being found out are not high unless they suspect fraud. And if they suspect fraud, they can go to your computer and they can go to your practice management system if they suspect fraud. It usually happens by mistake. Here's how it can happen by mistake. You have a client who's usually scheduled at 2:00 on Tuesday afternoon. That client reschedules to another time. That client reschedules to 2:00 Thursday afternoon. Then another client needs to reschedule, and lo and behold, you've got Tuesday at 2 open. So you put that client in at Tuesday at 2. You're used to writing, so you bill that client at Tuesday at 2, but you're used to writing this other client who switched to Thursday at 2. You're used to billing them on Tuesdays. So you actually bill them from the date that was on Tuesday. It's a mistake. It's still fraud. So be careful. Now, how do I know about these? Because I've caught myself, fortunately, before doing the billing, I've caught myself making the mistake. That's how I know it happens. I've also seen it documented. Okay, no cloning. What does cloning mean? Cloning means copy and pasting and leaving the same. It is something that a lot of clinicians do, and it is a very, very bad practice. There was actually a question that I got earlier somewhere. I don't remember whether it was in the chat or the Q&A. It wasn't a question, it was a comment about treatment plans or session notes I think it was session notes, looking the same session after session after session. There are times when sessions look very similar to one another, like if you're teaching a client some kind of mind-body modality or some kind of meditation or grounding. It can look the same from session to session, but you can't write it to look the same. Even you can at least have a different quote. In your intervention, put continued to challenge clients' cognitive distortions, continued to help client practice grounding meditation. And the progress is not going to look the same from one session to the next. Or if it does, you need to explain it in the assessment. I have a client whose progress felt non-existent. This was the guy who had schizoaffective disorder, who we got the paid friend for, the paid best friend. He was on so many meds. His cognitive processing was so slow that we often did the same thing over and over again. Maybe not every week, but we would cycle through it. And so in session notes periodically and in the treatment plan, I would explain under progress that client's meds slow client's functioning, and the client has extreme difficulty identifying emotions and gaining insight, but that he needs it to stay, he needs treatment to stay functioning. All right, I did this one. Handwritten notes must be in black and white with no whiteout, and amendments clearly marked and initialed and legible. Anything handwritten has to be legible. If it's not legible, you will not pass. By the way, I want to explain about passing an audit. Most audits are graded on or evaluated on a percentage scale. So they ask for 10 or 20 sessions or all the sessions between this date and this date, and they review them, and they have a rubric for what works and what doesn't work, and they check off what doesn't work, and they figure out the percentage of what doesn't work. And then they apply that percentage to all of your notes for that person. And that's how much money you lose. Okay. You don't want to do that. All right. You asked me earlier. You didn't ask me about this one. What you asked me about earlier is coming up. I'm sure that there are some people, some clients you see twice a week. I see a Medicare client twice a week. I have been doing that for, I think it's been 4 years since we started working together. It's really necessary to keep her functioning well. And she's on disability, but she functions remarkably well on disability, except that she cannot do a job over a certain number of hours per week. The second session of the week, I always put second session of the week is medically necessary due to pressing treatment plan issues, or due to mother's recent death, or due to emotional reactivity to something, or I don't know, fill in the blank. I actually have a blog post about second sessions and 90837 and how to justify it. Document and bill all your sessions. Oh, I put this one in because some therapists say, oh God, it's just one session. I'm not going to bother. Forget it. Don't do that. First of all, don't lose the money. We work hard for our money. And second of all, if you don't document it and somebody says, well, I saw so-and-so, I saw Beth on September 4th, and you don't have that documented, you're going to be in trouble. And yes, we do our work because we love our work, but we can't give our work away. This is my rant about time. We don't get paid for our work. We get paid for our time. What comes with our time is our expertise. So we have to bill for the time we spend, for the time we are allowed to bill. Bill your diagnostic session as 90791 because you get more money. Remember, you get paid for your time. And you get more money for this one. And also keep in mind that when you're billing a 90791, you're also writing a treatment plan, which takes more time that you're not getting paid for. I will, by the way, I will answer some of these other questions in the chat and the Q&A when I'm finished with this. Never bill a chance momentary social encounter as a valid therapeutic session. Now, I know that this seems like I don't need to say it, but therapists do it because they're, I don't know, maybe they're desperate to get the money. But it's not a valid therapeutic session unless you're sitting down and having a session. Here's an example. I was once in Linens and Things before it closed, so you can tell how long ago this was. I was there with my husband on the weekend, and somebody runs up from behind me and says, "Beth," and she puts her arm, she wraps her arm around me from behind like this. And I go like this. Like, what? And my husband is at the other end of the hall of the corridor, and he comes charging in thinking I'm getting strangled. And I'm going, "Oh, it's you. Oh, how nice." And inside my head, I'm going, "What are you doing strangling me?" And my husband comes charging up, and I say, "Honey, this is so-and-so. I work with her. So-and-so. This is, I live with him," right? I did not bill that as a therapeutic encounter. I saw one of my clients taking a walk at the Arboretum. It was lovely. We said hi. It was very sweet, but I didn't bill for the session. I will tell you, however, that the person who threw her arms around my neck, we had a conversation the next session about boundaries and about what it would look like if we saw each other in public. And after that, I put in my informed consent, when I got into private practice, I put in my informed consent what would happen if we met in public. Provide evidence that your treatment is being provided in a culturally competent manner. That's one of the reasons I include all of those questions in my diagnostic summary around trauma. And that is also why on my forms I include gender. And even on my diagnostic summary, I have pronouns. It's not required, by the way, but I include it on mine. The pronouns people like to use, and the name the person wants to be called. Those aren't required. It's what I put on there. Communication with the PCP and prescribers and other collaterals is documented at the beginning of treatment. Recommended every 60 days and at termination. Now, I do not communicate with every PCP and prescriber and other collaterals every 60 days. I will tell you that is what is recommended, but I definitely do it as needed. And I do it at termination. Okay, justify the second. Oh, this is twice. Justify second session in 1 week. Sorry about that. Justify using 90837. I wrote a blog on justifying using 90837. And I have never had a problem using 90837, but that doesn't mean I won't. And I justify using 90837. I actually have a little crib sheet here, and you can find it on my website and my blog. And I have it right here in front of me because I don't always remember immediately. 90837, medically necessary because client is unable to share with others due to nature of problem, because of history of severe trauma impacting current functioning, because of life stressors impacting multiple domains of life, due to client presenting with acute issues, due to history of trauma, due to client in crisis, due to multiple life stressors, due to limited healthy support network, time needed to address and contain intense emotion, severity of diagnosis and intensity of clinical presentation. I write that on every single 90837 I have. And in fact, on my new form, I have a cue to include it. All right. Do not audit your own records. If you get audited or you have to turn them over, do not audit your own, do not review them. It's too easy to make mistakes. Mistakes really do happen. I make mistakes. I periodically look over my records. I don't know what motivates me to do it. I just do it sometimes. And I find mistakes here and there, and I will correct them. Find somebody who you trust to do it. I have people I trust to do it. The name and the date of birth should be on each page of every document. Now there is one last one, and it gets its own slide. Choose your templates carefully. CMS, Center for Medicaid and Medicare Services, discourages templates that rely on the excessive use of checkboxes, predefined answers, and limited space to enter information. You need to have narratives. Checkboxes are okay. They're fine. As long as there are narratives to explain what you've done. Limited space templates generally do not provide enough or sufficient information to demonstrate that medical necessity meets criteria. All right. I'm going to answer a couple of questions. And by the way, if you have not put your email in the chat, now is the time to do it. You will get updates from me and blogs from me and all kinds of special resources. Can you say a little bit more about no-shows and cancellations and how to document what we need to include? I think I said that. Just document, just document that it was a no-show and what you did to reach out to the client and whether you expect to see the client again. And cancellations, document how the cancellation happened. Therapist got a text at 3:59 stating, client called. Client's mother called. Client could not reschedule for later in the week after alternative date offered by therapist. Can we justify twice weekly sessions for a new client if they've been released from the hospital for self-harm? Absolutely. Would you update a treatment plan first or just include in a progress note? I would include it in the progress note. Although if the treatment is going to change dramatically, you might write a new treatment plan, but only if the treatment's going to change dramatically. Can you bill 90837 if the client arrives late to sessions? If you get the required number of minutes in, you can, but not if you don't, or because it's face-to-face. When you do a session note, do you have to include getting consent to do video sessions each time you meet? No, you don't have to get consent each time you meet. You have to get a consent, period, because there's all kinds of things that that the client has to agree to in order to be on video sessions. Go check out my blog. I think you can get a free consent on my from one of my blogs. Okay. Some of these questions. All right. All of these in the Q&A were also in the chat. So got them all. Now, somebody asked me earlier, maybe it was in an email, not an email, in a Q&A. What about EHRs? Do private practice therapists need to use an electronic health record? First of all, I'm going to tell you that Simple Practice and Therapy Notes and all of those programs are not EHRs. An EHR is a very complicated, complete system used in large organizations or large group practices and agencies. They allow providers to communicate with each other and to communicate with the client. Practice management systems are not EHRs because providers do not communicate with each other. I'm sorry, my eyes are closed, but I've got to really focus, and this is how I really focus. So that these companies call themselves EHRs, I believe, is more like false advertising. I don't like it. They are practice management systems. We are not required to use them. We can use paper forms. We can use forms that we develop ourselves and put on and type into and save on our computers. You can buy them from other people and get them. I know bunches of therapists who have them available. We were told at the beginning that when EHRs came into being, that private practice therapists were going to need to be on EHRs. That was in 2015. We are now at 2021, and it keeps getting postponed and postponed. That's partly because it's an expensive proposition. Developing developing these digital practice management systems so all of them can communicate with each other and with the EHRs, the real EHRs, is a very complicated thing. I don't even know if anybody's actually tackling that yet. It's very expensive, and to require a therapist to have one is, they've realized it's pretty unfair. So no, we don't need an EHR. We need legible notes, and we need notes that meet medical necessity standards. So there are pros and cons to notes. Excuse me, not pros and cons to notes. There's pros to notes. The only con is the time writing it. There are pros and cons to practice management systems and online programs. That practice management and online programs are the same. Paper forms are the same as forms you type up and store in your computer. If you want to have a system that really embraces your clinical voice, do your own paper forms or forms that you develop and store in your own computer, because you will have your own clinical voice in those. if you want a system, if you are not all that interested and you want a system with drop-down menus only, which you know I don't endorse, think about then think about, do you want that system to include billing? If yes, get a practice management system. If no, do you want to save money and do your own billing? Do that. If you want to save money, if you don't want to save money and you do want your notes to contribute to clinical thinking, get paper. If you don't, get an online program. There are online programs. Some are better than others. I'm not going to, because I've reviewed a whole bunch of them now because people ask me to do that. I'm not going to endorse any of them in this program. What I'm going to say is you want to go through your program and you want to look at that empty hole that says clinical content or what happened in therapy. And you want to create a template for yourself that includes all the clinical content you want to create and do it in a systematic way. Does this make sense? I hope it makes sense. You have just learned all the T's that need to be crossed and all the I's that need to be dotted. I know it was a lot of information, but what I want you to know is you know how to do this. Now, do you need to go back and write all your treatment plans? You know, if you try and do that, I think you're going to wind up with stomach aches and headaches, and you're going to feel really sick and you're going to want to quit. I would recommend writing a treatment plan for either a complicated client so that you can actually use it to figure out treatment and it will contribute to clinical care, or write it for your next client coming in. If you're audited and you don't have a treatment plan, it could be a problem for you. I'm not going to lie about that. But if you don't have it, you don't have it. I'm concerned about you burning out. If you don't have session notes, and you're really behind on writing your session notes, one of the things that you can do is simply write date of, have a little template made up that says, name, date of birth, date, code, time, and this session addressed treatment goals, and then sign off on it. At least you have got something that says you have a note. It's not good, but you have something. If you want to catch up on all of your notes, which is a good idea, but I'm not going to tell you you have to, but it is a good idea. The first thing to do is not get behind on your notes. Start writing your notes regularly and get yourself to the point where you are writing them regularly so you don't fall any further behind. The next thing is make a plan for yourself. Count out how many notes you need to write, how many treatment plans you need to write. Know that at the beginning, it's going to take you a half an hour to write a treatment plan. You're going to get it down to 15 or 20 minutes. It might take you longer to write a treatment plan at the beginning. It's going to take you longer to write your session notes because you have to go back in time. It's not going to take you 5 to 10 minutes. It's going to take you longer. Set up an hour a day or 30 minutes at the end of your day. Don't make yourself do it all in one fell swoop. First of all, you can't. And second of all, you're going to make yourself sick. Please don't do that to yourself. Okay. Again, if you haven't put your email address in here, please do so. I am going to type my website address and how to reach me, although it is on the PowerPoint template. Learning objectives. So did you learn how to describe can you apply the clinical documentation process to write effective treatment plans, session notes, case consults, discharge summaries, and diagnostic summaries? No matter what system you use, you can describe it. You may not be able to do it yet, but you should be able to describe it. You have a sense of how to do it. Document how to translate your work into the behavioral language required by insurance companies, no matter what therapeutic modalities used. I sure hope so, because we spent all of the treatment planning session doing that, and a major part of the session note. Can you apply the golden thread to justify medical necessity? Because that's number 3 of the objectives. And explain how to write clinically useful notes that document the progress and protect confidentiality. And identify potential legal, clinical, and ethical red flags in the documentation process and how to avoid them. That is your presentation. Thank you. These are additional resources. By the way, just so you know, this is a copyrighted presentation. And if you use any of it, you need to get permission from me. Please go to my Facebook page, follow me at documentationwizard.com. That's my page. You can also join my group, Clinical Documentation for Psychotherapy Therapists. You can give and get support from other therapists, and I post there as well. And don't forget my blog, because there's lots of good information on my blog. Things that I went over very briefly, I go into more detail. And then again, how to reach me. You all have been oh, you feel empowered, Paula. I am so glad. I really want you to see this as not just, oh my God, I've got to go do my documentation, but that this actually will help you with your clinical work. That's what I want for you. I am no longer afraid to bill 90837. Yes. Some insurance companies don't cover it, but don't be afraid to actually document what you're really doing. You are very welcome, one and all. It is 4 o'clock. I'm going to go write my notes now. Good for you. Oh, I'm glad I've made it less overwhelming. Thoroughly. Thank you so much. Oh, these wonderful comments to read. I want to thank you very, very much.